scope, education, and barriers.
Morning, everybody. Are we seeing the slides? Great. So I'm Tracy Morton. I'm calling in from Haida Gwaii, land of the Haida Nation. I work at the Haida Gwaii Hospital and Health Center, and I'm also clinical faculty at the UBC Department of Family Practice. So our study is actually derives from some work, recent work, a project that RCC has taken on, examining and supporting use of point-of-care ultrasound in rural BC. So to inform this work, we created a survey in evaluating POCUS in rural BC to look at the scope of use, education for those using it, and what barriers exist for those who are trying to use it or currently seeking to use it more. Very grateful to RCCBC for both hosting the Rural Health Exchange and for supporting this work. My disclosures are as follows. I have no industry conflicts of interest, but I have received speakers honoraria for mostly POCUS related talks. I teach for the House course, which is a UBC CPD course using to teach providers how to use ultrasound, and I'm on contract with RCCBC. So what is POCUS? I mean, not everybody here is a clinician. So it's defined as an ultrasound which is performed at the point of care by the treating clinician, and it's then quickly integrated into clinical assessment. So it's shortening that time span between your assessment and a diagnostic procedure. It's been shown to be lots of evidence on its use. It's much faster than the typical way of acquiring diagnostics. It's efficient. It saves other forms of imaging. And in rural settings, we are fairly sure that it saves things like transfers. It's also quite safe, especially when done with a certain basic skill set. Number one, we can save doing things like CT. And procedures are vastly more safe when done with ultrasound guidance. So a needle or an IV, when placed with ultrasound, is much safer when you can see where you're driving. So most of us have had an ultrasound. These are some of the CART models that are out there. These are actually 3 from our site that we've had over the years. But this is the next generation. These are all handhelds that are available on the market for really about 1/10 of the cost. So they're cheaper and they're smaller, and they've led to the widespread democratization of this technology. So it's now to the point that even medical students are buying these early in their training. So here are a few examples of actually from our site, some things that we've diagnosed. This first scan is a kidney stone leading to hydronephrosis of the kidney. You can see a baby. This shows a large pulmonary embolism causing strain on the heart. And this is a picture of, we're characterizing a breast mass from which we were able to biopsy right away with the first presentation in the office. So one can see how useful this is. So our study was hoping to answer some questions about the spread of this disruptive technology. We really had no sense of how widespread its use was. And so we created a survey. It's again, like a last presentation was done with Qualtrics, an online survey platform. And we divided our questions into scope, where we wanted to find out who is using it, where in BC, and in which practice settings, whether it's hospital or clinic or emergency. We also wanted to find out the scale, when is it being used, and how is this information being integrated into decision making. We really wanted to also understand what some of the barriers and supports needed were. So we surveyed through a series of a database that we had with RCC, all 2,000 practitioners that are working rurally in BC. Our response rate was, we had 231 responses with an estimated response rate of 15%. This shows the breakdown of the health authority responses. So very gratifyingly, we had a large number from Interior and Northern Health. To the majority of our responses where we've got the bulk of our rural communities. In terms of utility and frequency of use, about 61% you were using it at least once daily. So wide, these are your early and frequent users of POCUS. Interestingly, the settings, we see the spread of this outside of the emergency department, which is where POCUS was born, into both hospital settings, where it's used half the time, and in the clinic, which is used more than half the time, also in long-term care. So we see this technology now creeping into other practice settings. In terms of utility, most reported very high impact. So this graph shows that at least 25% of the time or more, it was deemed useful. So very high impact versus not using it. This shows that there's very little, oh, sorry about that. This shows very little exposure to POCUS during both the top two bars in undergraduate medical education and a residency. The black bar is no exposure, and 23% of respondents reported, under 5 hours. Let's go back here. So both for procedural and diagnostic implications. So there's a real gap, and most users are reporting that they acquired these skills after their medical education was complete. In terms of machine access, we're seeing a change over the past 10 years, so that those cart-based machines alone 50% of the time, and handhelds alone about 15 or 6.7%, and then or both, we see widespread access. In terms of supports required or suggested to be required, funding for courses was hands down number one on a ranked list of possible supports. Again, training to use these machines. And then again, reflecting the smaller, more affordable funding for handhelds was number 3. In terms of attitudes, on a Likert scale of 1 to 5, from 1 disagree to 5 agree, you can see the top 2 really point to education being available earlier on in the medical education spectrum, from undergraduate to postgrad. That's the number 1 recommendation for practicing providers. It's time consuming and expensive to acquire these images when you've not been exposed throughout your training. And interestingly, most felt that rural physicians should be using POCUS as the standard of care. And then to summarize, well, I guess we'll see some of the key conclusions are that it's very clinically useful, contributing meaningful information about half the time it's used. Supports needed are both educational and financial. And yes, the response rate was low, indicating the early adopters are more keen to answer a survey. And I guess the key conclusion that I think we'll probably want to action is that reform of the medical curriculum and residencies is needed. And this survey will be used, I think, to further those conversations. Key supports were RCCBC through the Rural Physician Research Grant. We've had support from Jason Curran and Tracy DeLu, one of our hosts today. And the Rural RCC's POCUS strategy is where we hope to center some of this work for implementation down the line. This is our research team. And I'll pause there for questions. Thanks for your attention.
Wonderful. Thank you so much. And let's see if somebody has a question. And maybe I'll just, I'm hoping that is there plans to publish it is my first question, because I think this would be very helpful. The second thing is, did you collect any demographic information, particularly relating to age or year of graduation? Because I think that would be a really interesting stat to potentially delineate the data in terms of were they in practice 15 years? Have they just been in practice? That might give you some information about the undergrad and postgrad question, although I don't think your conclusions are wrong.
Yeah, I mean, this is fairly new technology. So yes, the demographics we did collect, and a few things. One is the more rural you work, the more you're kind of encouraged, almost out of desperation, to be using it. So rural location of practice was an important feature, and then how young you are was also. We don't have a specifically statistical correlation that we ran on that. This is being published, or we're aiming to have it published. We're just in the final stages of submission to the Canadian Family Physician, because this is, we think, important, nationwide, to, BC, how representative is BC to the rest of rural Canada? I'm not sure, but the same pressures of practice apply throughout the country. So there is a national level survey that's being launched as we speak. So it is a growing area of research interest, and we're only going to learn more as time goes on. Necessary to actually inform how best to support it and help this scope and spread of it.
Great, thank you. So if do you have any demographic information? Do you have age, or that you could kind of reanalyze with the survey? Because that might be really interesting to do a chi-squared and find out age of graduation. If not, maybe you could add that to survey questions in the future.
Yeah, so we do have that. It could be run. I think at the point of review of the manuscript, if it's asked for, we'll do so. We commented on the demographics in the paper, in the manuscript itself. And we'll see if we need to run a statistical analysis. It is quite a small, relative to the denominator. So, making firm conclusions can be a little difficult that way.
And then maybe one last question. Let's just see if anybody has a question, feel free. Tracy, was there anything that you found surprising from the data?
Just how indispensable it's used, indispensable it is for those that are using it frequently. And I would probably count myself as one of those practitioners. I mean, I could not work in a setting in which I didn't have it. Honestly, I would feel unsafe, frankly, in the sense that I would feel like I'm blind, literally blind. We actually look into a person's body. We see the heart beating. We see the lungs breathing. We see pee being made in a kidney. I mean, it's remarkable what you can see. You see food being digested. You see blood moving through the liver. It's really, you're blind without it. And it's almost like when you start using it, you develop a new sense. It's like if you've been blind your whole life and now you can see. It has that feeling for those that are frequent users. So our study supports the idea that it's become indispensable, and it's really what's inspired me to want to look at more systems supports and systems change.
Thank you. Allison James has a question for you. Go ahead, Allison.
Tracy, great work. It's great to see your presentation. Just wondering if you are planning any research on we'll call them the adopters to POCUS. So those people that haven't adopted POCUS in their rural practice. Is there any thoughts on trying to understand their perceptions of using the technology?
Well, two things. This survey was an attempt to reach them, like it was to everybody, whether they used it or not. We were explicit in our mailings that we wanted to hear from everybody. Unfortunately, I think it was 1 in 10 of the respondents did say that they didn't use it. So that's the first thing, is it's difficult to reach those that don't use it for a variety of reasons. It's been shown that physicians are the most surveyed profession out there, so there's a lot of survey fatigue. Number two is we've looked at maybe addressing or finding the answer to that question through looking at barriers to use. And it's no longer machine access, which is what it historically has been. It's much more, we need training. We need to know how to use this. Practically everybody said that they understand it's useful, but they need training. So that's where we need to devote some work. And particularly medical students need training. Residents, so that we're not taking practitioners that are out in rural settings and saying, okay, you've got this technology, here's a machine, go ahead and use it. It's really inefficient to take practitioners piecemeal, one at a time, and get them upskilled. It's expensive and it's very time consuming. And I think it's unfair to them, considering how useful it is to not provide this as part of your core medical education and residency.
Great, thank you. Sounds like a conversation with Cheryl Holmes as undergrad curriculum, and Adrian Yee might be, I'm sure you're going down that path, but great work, Tracy, and congratulations to you and the team. Very important stuff. So we'll go on to the next presenter, Nicole Ketter, and Sharon is San Mi from UBCO, and they are going to present their work called Understanding Community Health Nurses Conceptualizations of Health Equity. So thank you, Sharon and Nicole, over to you.
No, thank you. Thank you for joining us today and listening to our presentation on our study. My name is Sharon Ilasami. I am a fourth year nursing student at UBC Okanagan, and I'm also a research assistant at the Health Informatics Equity Lab at the School of Nursing there. Today, I am joining you with my colleague.
Hi, everyone. I'm Nicole. I'm a second year Master's of Rehabilitation student at UBC, and I'm also a research assistant in the lab with Sharon.
Yeah, and today we'll be presenting on a study titled Understanding Community Health Nurses Conceptualization of Health Equity. Before we dive in, today we are joining you from the unceded, occupied and traditional territories of the Syilx Okanagan people. And we are going to start off with our introductions to our team and the researchers. We're going to give a background highlights to where our studies stem from and why we're conducting the study. We're going to talk about the methods, results, and also close up with any questions that you might have for us. So here's a brief introduction to our team. We are composed of 6 principal people and from multidisciplinary fields, ranging from nursing to social work, to electrical and computer engineering, and to rehabilitation science as well. We did want to start with a poll question. We're hoping the chat will be working, but if it's not working, you can just answer the questions in your minds, or you can, I don't know, think about it later on as well. But our first question is, do you think that electronic health records has an influence on health equity? So yes, no, possibly, or haven't really thought about it. And we also have another food for thought, which is, what is your understanding of health equity? The reason we ask this question is because we have discovered from our study that nurses have varying conceptualizations of health equity, which we weren't really sure about what to expect from the study, but the extent to which it varies is a little questioning. So what is your understanding of health equity? How would you define health equity, and how do you practice health equity? So the reason we ask this is because of subjects such as data bias and AI bias. AI is inevitably made from data, and once such data is inequitable, the AI that is created from such data is also inequitable to certain population. We've noticed that a subject called implicit bias, which is when clinicians have bias, makes its way into clinical documentation, which will have negative impacts on data and the ability to create an equitable health tool and healthcare tool for patients in the future. Certain topics and subjects that we found missing in nursing charting electronically as being topics such as relational care, patient advocacy, social determinants of health and its assessments, and intersectionality of certain electronic charting tools, and also trauma-informed care as well.
Thank you. So overall, this study is one small part of a larger study, which the ultimate goal overall is to understand how community health nurses conceptualize and subsequently document health equity in the electronic health record. And with this, we are hoping to develop a gold standard corpus of health equity language. And then this equity dictionary, if you will be used to code equitable AI algorithms, or at least that's the goal. Next slide, please. So just focusing on the first part of the study, it is a qualitative descriptive study, which is informed by Strauss and Corbin's grounded theory approach. So we've been recruiting community health RNs, RPNs, and LPNs who are working in either Interior Health or Vancouver Health authorities. We are conducting one-on-one interviews via Zoom using a semi-structured interview guide. And from these interviews, we've created a preliminary code guide, and we conducted a focus group with 7 nurses who participated in our one-on-one interviews. And in this member check session, we presented some of our preliminary codes to check for perceived accuracy from the participants and to further explain some concepts that have not been well defined yet through the interviews. Next slide. So far we've conducted about 20 interviews. We've had 6 participants, or about 1/3 of them, who are working in a rural community. The majority of our participants are from Interior Health and only a handful from Vancouver. 2 participants have been men, while the rest are women. And 3 participants have been LPNs and the rest are RNs. Next slide. We do have some emerging interview concepts from our analysis so far, and I've just picked a handful of the ones that we feel best explain our entire code book. So firstly, as Sharon said earlier, we're finding there is a varying understanding of equity. And this makes sense because we all have a different view and perception of what equity is. And this perception also precipitates into how nurses choose to address and incorporate equity into their practice. One way in which nurses are incorporating equity is through advocating. So they'll advocate for their patients for particular resources and also really encourage patients to advocate for themselves. And we're also commonly finding that a person's social determinants of health are influencing the care that they receive or don't receive. So this can look like nurses making specific care plans to incorporate some of these social determinants of health, or specifically not providing resources if they're not available to the clients. And in particular with rural clients, some nurses say they're not going to recommend certain resources if those services aren't provided in the area. Nurses aren't going to recommend their client see a physiotherapist if the closest one lives an hour and a half away. So in that way, that's how the social determinants of health or living rurally is influencing someone's care that they receive. And similarly, we ask questions if there's any common trends or topics that clients are concerned about. And we're finding with rural clients that they're really concerned about their limited access to resources. And they find they just don't have the same availability to the services that larger urban centers do. As well as some nurses have noted that there's quite a bit of intersectionality of rural living with other social determinants of health, such as socioeconomic status or ethnicity. And a large part of the study is not only how equity is conceptualized, but then how it is documented in electronic health records. We found there's minimal documentation area specific for documenting inequities. And if nurses want to find social determinants of health or ways that this is influencing someone's care, it's in bits and pieces across someone's entire health record. And that can make it very difficult to find that information given the limited time that nurses have. And finally, we find that interoperability has been an issue. So these systems don't communicate well with each other. And a lot of the time, things will have to be double documented and takes a lot of time to get that whole picture again when you're looking across multiple systems. So overall, we're in the midst of analyzing our results, and we have another 10 interviews planned. So the future directions of the study is continuing fleshing out our code book, and stay tuned for our final results, hopefully in the next year. And with that, it's taking a second to think about. There we go. Thank you so much for listening to our presentation. Sharon and I's emails are there if anyone has questions that we don't get to, as well as the principal investigator, Dr. Charlene Ronquillo. Their email is there, Twitter and website. And thanks again. Hope you enjoy the rest of the presentations today.
Great, that was really interesting. Thank you, Sharon, and thank you, Nicole. We'll just see if we have any questions. Maybe I'll start with one. You mentioned relational care in your opening slides. Can you tell me or define that a little bit more? What do you mean? What's the definition? How is that meant? Maybe that's a big question. Relational care.
Yeah, it is a big question. And like we said, it varies from nurses to nurses, individual understanding and perception of it. We really still are trying to find a code book and a standard to base our data and observations from. But in general, we do define the relational care as the ability of a nurse to not only go into a patient's home with intent of just curing their disease, so not curing the disease, but helping them with wound care or doing the nurse activity that they've determined themselves to do, but also looking at what is their family relation like, is there support available for the patient? Is there food in their fridge? Like it's more so centered on social determinants of health and how that as well is influencing the care, just taking things beyond the medical and the medical aspects of things. Yeah.
Thank you. That was well stated. Let's just see if we have another question. Okay, maybe I'll ask another one. You mentioned the ultimate goal for this is for language for the EMR, like a guide or a code book. Can you describe that a little bit more? Would that be recommendations for how to actually put these things in? Would it be a change in the EMR in terms of the fields that someone might see? How do you see it kind of playing out?
That's a good question. I believe, so the first step we've done is create these keywords and ask nurses how they are describing social determinants of health and how they've seen it described in the record. And from that, and usually these things come up in the narrative notes rather than in tick boxes and stuff. So seeing how it's described. And then we're going to take that dictionary, and sorry, this is the second part of the study that we're not quite as involved with, but to my knowledge, they're taking that dictionary and they're going to use AI to also look through health records to see if that is how it's being described. And then when we have this dictionary, we can, I'm not sure, Sharon, do you have anything else to add to that? This is the second part of the study that we haven't really rolled into yet, so it's not super well defined yet.
But yeah, about the code book, we are asking nurses during the interviews what specific phrases or what specific words do they see used to describe health equity in their charting. And we do make note of the phrases that the nurses are giving us. And once we're making a table of these phrases and using other resources such as SNOMED and the ICNP browser to kind of standardize our terminologies. And from that, we are hoping to create a standard terminology that is valid and can be backed up by other systemic reviews and other valid research, and hopefully create a code book from that. If that answers your question, hopefully.
Yeah, that's great. No, you guys are doing a great job with the question. And it's really, really interesting work as well. So no, that's great. Wonderful. Thank you so much for your presentation and your great work in this area. Very important stuff. Great job, and thank you again.
Thank you.
We're going to go to the next presenter. It's Kelsey Chamberlain from UNBC. And Kelsey's going to present Bodies of Strength, Promoting Prenatal Well-Being of Young People in Rural, Northern, and Indigenous Geographies. Sorry, I seem to have caught the virus. Everybody has. My voice is a bit off, but over to you, Kelsey.
Hi, thanks, Brenna. Everybody can see my screen okay? Perfect. So yeah, hi everyone. My name is Kelsey Chamberlain, and I am zooming in from the Wet'suwet'en Valley in northern BC, which is in the never ceded territory of the Wet'suwet'en. And today I am sharing a little bit of my master's thesis research, which is entitled Bodies of Strength, Promoting Perinatal Well-Being of Young People in Rural, Northern, and Indigenous Geographies. So I'll spend the first half of my presentation introducing you to my research setting, how my project came to be, and a little bit of background information on early age birth and perinatal well-being. I'll share my research question and objectives and how I wove a methodology for this research project. In the latter half, I will share a little bit about my interviews with knowledge holders. However, I am just wrapping up my interviews this week, so I'll just provide a few initial reflections and touch on my plans for knowledge translation, after which I look forward to answering any questions. So as I mentioned, I am zooming in from the Wet'suwet'en Valley in Wet'suwet'en Territory. This is where I grew up, it's where I currently live, and it's also where my research takes place. So the Wet'suwet'en Valley includes the communities of Houston, Telkwa, Smithers, Whitsett, and the Hazeltons, which are in the Upper Skeena watershed, where the Wet'suwet'en or Bulkley River flows from its headwaters south of Houston into the Skeena River, which is in Gitxsan Territory. So about 2 years ago now, I was working as a birth and postpartum doula in the area, and I heard that a local organization, the Northern Society for Domestic Peace, was developing a supportive housing program for young mothers in the community of Smithers. So this program, On Her Way, is set to open this coming winter or early spring, and will provide pregnant and postpartum young people with housing and integrated health and social services for up to 2 years. So I pitched the idea to the executive and program directors to use my master's thesis research to help inform the program development, which they were keen to have me do. So the need for this program and my research stems partly from the long-standing early age birth rates in Northern BC being the highest in the province. So this graph here shows birth rates across each health authority, with the rate of births for under 20-year-olds in yellow and 20 to 24-year-olds in green. And while the rates differ between the two age groups, they remain highest in Northern BC at roughly 2 to 3 times the provincial average. So when I'm referring to early age or young people, I'm referring to folks in these age groups or under 25. Now, it didn't take perinatal statistics for me to know that many young folks in the North start parenting at an early age. Growing up here, it was a common experience. But when I turned to the literature on early age experiences of pregnancy, birth, and early parenting, most research tends to highlight the adverse physical, emotional, and social risks and poor outcomes for both parent and baby. And while these are important to consider, a growing body of work points more to the underlying determinants of health that lead to these various risks and poor outcomes. I'm sure many of you are familiar with the social determinants of health. However, my research extends beyond just the social to consider geographic, environmental, and structural determinants of health and well-being. And because my research takes place in the context of settler colonialism, involves Indigenous parents, and myself as a non-Indigenous researcher, my work is greatly informed by the Indigenous birth resurgence movement, which broadly represents ever-present resistance and resurgence of Indigenous birthing practices across Turtle Island. So I turn to this body of scholarship and voice to center Indigenous-led and self-determined solutions when thinking about the well-being of young Indigenous mothers. And this is where my research lands in looking towards determinants of perinatal well-being. So I'm drawing on Waitful and colleagues' 2020 definition, which I think provides a nice starting point in thinking about perinatal well-being, which they describe as a dynamic and subjective individual experience consisting of physical, emotional, and cognitive elements that are determined by broader social, environmental, and structural forces. So there is a small body of research that explores perinatal experiences of young people in Prince George. However, no research, to the best of my knowledge, looks beyond this relatively urban geography of Northern BC. And so this is the gap that my project seeks to address in the Wet'suwet'en Valley. So I am asking what promising practices promote perinatal well-being for young people in rural, northern, and Indigenous geographies. My objectives here are to translate promising practices emerging in mostly urban and southern geographies to be relevant and applicable across Northern BC, to inform On Her Way with place-based and community-specific evidence, and to contribute to Northern and Indigenous health equity and reproductive justice more broadly. To begin answering this question, I chose to weave a methodology, which is inspired in large part by Ryder and colleagues' work in 2019, in which they draw on principles of weaving to bring together Indigenous and Western methodologies to create a research interface best suited to the particular research space and study. I am also a weaver, so this approach resonated with my practice of weaving in that the materials you use don't just overlap or sit beside each other, but intertwine and create structural integrity and a whole new material that's both practical and beautiful. So while my research is grounded in qualitative and interdisciplinary inquiry, I also weave in anti-colonial and intersectional praxis. So I draw on both anti-colonial and intersectional methodologies because while this research takes place in the context of settler colonialism, involves Indigenous young people and myself as a non-Indigenous researcher, it also includes people of diverse identities and social locations. I also weave in strengths-based methodologies that underpin efforts to move away from deficit-focused research. And my primary method of enacting this research was through land and story-based interviews with knowledge holders. So these interviews centered on Leanne Simpson's idea of land as pedagogy and the intimate relationship between land and well-being, as well as the use of story as method. So over the last 2 months, 10 knowledge holders have generously shared their time with me and participated in an interview. Knowledge holders were invited to participate if they had lived experience of becoming a parent or before the age of 25, or had experience supporting young parents as a healthcare or social service provider in the area. And some knowledge holders fell into both categories. So each interview lasted about an hour, and our conversation flowed through several domains of perinatal well-being in a semi-structured and flexible way. Now, I hesitate to share any findings from my research as I am just wrapping up my interviews and I haven't started my analysis of the knowledge shared with me yet. However, I wanted to just share some initial reflections and touch on an idea that emerged across each of the 10 interviews. That being, just across the board, knowledge holders talked about many different relationships that were important to supporting well-being during pregnancy, birth, and postpartum. So for some, it was a family member, or for others, a special connection to a friend or community member or service provider. And for most, a relationship and connection to land or nature, as well as cultural identity, was also really important. So thinking about perinatal well-being as highly relational has me reflecting a lot on a Wet'suwet'en teaching shared by Wayestes Sandra Martin Harris, that connection is medicine. And this idea is also key to the Indigenous birth resurgence movement and is growing in acceptance and understanding in Western approaches to health and well-being. With the work by Wadeful and colleagues that I mentioned earlier also highlights the importance of relationships to well-being. So I'll just emphasize that this is very preliminary. You'll have to stay tuned for my master's thesis, which should come by early summer 2023. And beyond this, my plans for knowledge translation also include providing the Northern Society for Domestic Peace with a summary of my findings to help support their program development for On Her Way. I also plan to do a community presentation to share my work locally, which has been requested by folks who are interested and curious about my research process and findings. And because there is such a dearth of published research on perinatal well-being in Northern BC, I do aim to submit a paper for publication. So I just want to thank you all for being here, and a big thank you to Tracy DeLu and RCCPC team for putting on this event. And of course, I want to acknowledge the knowledge holders that shared their time with me this fall, along with my supervisor, Dr. Sarah DeLeo, and committee members, Drs. Jesse King and Margot Parks, as well as Bronwyn Young from the Northern Society for Domestic Peace and my generous funders. You can see across the bottom, and I'd be delighted to answer any questions, or you can shoot me an email, which is there on the slide.
Great work, Kelsey. Thank you so much. I love the weaving methodology. That first I've heard of that, and I think it's great that it's referenced, and then you really brought it to life in terms of how you're going to approach it and making a new and beautiful fabric. I think that was just wonderfully done, and really interested in your results. Can you talk a bit about your recruitment of
Yeah.
your study participants? Did you do that through the center? Did you cast a wider net? And any practices that you found were really helpful for reaching out to this group to learn more about perinatal well-being?
Yeah, thank you for that question. It's actually a big part of my reflection process right now. So my recruitment methods, I reached out to known networks. So having been a birth and postpartum doula in the area, I am fairly connected with health and social service providers. So that was quite useful. I did posters, and actually one of the most successful methods was Facebook. Sharing around, folks sharing my recruitment poster. And I will mention that having existing relationships in this community and being connected was absolutely key to my work and connecting with knowledge holders who participated. I think without my, existing relationships to this community and folks in the area, it would have been a lot more difficult, especially having people come and talk about their very personal lived experience, often quite traumatic. So having that vulnerability and having that connection to community was absolutely central in having folks share their time with me.
Great, that's really interesting. And thanks for sharing kind of what has worked in terms of relationships and some of the outlets for doing that. Did you have, were you trying to survey people based on age of the children at all, in terms of like having a longitudinal approach, or did you want kind of people that were like newer to parenting, or did you limit that?
No, I actually left it quite open. I was interested in talking with people who had lived experience in this area. So who are from this area, who had their kids in this area at early ages. I didn't limit it to any time frame within, having kids in the last 5-10 years, but it did end up being that sort of more close time frame of in the last sort of 5 to 10 years.
Okay, interesting. Let me just check and see if we have any questions. Okay, so maybe one thing, is there anything that's really surprised you, or from the data, from approaches? Is there anything that you would share on that front?
There are a few things that I would love to share, but I think I'm a little hesitant at this point until I spend some more time sitting with what everybody has shared with me. And particularly in considering where I am in rural, smaller communities, I want to be really careful about how I share the information that people have shared with me, just because, even though we, use certain methods to support confidentiality, it's really tricky in small communities. So I just want to be really careful about that. I will say, I think I will have some interesting things to say about living in the North and being in a rural place and supporting well-being, especially during the winter. As we're in November, we're coming into December, start to think about all the challenges in supporting our own well-being during the cold, dark winter months. And so that would be sort of one of my sort of surprising or fun things that I'll get to talk about.
Great, thank you. So good luck with the completion of your master's. I think you're well on your way. I love how you've got I love your structure. I love the weaving pieces, and I'm really interested to see how this goes. And yeah, great work. Thanks for sharing it with us today, Kelsey.
Thank you.
Okay, I'm not sure if we have Mike. Let's see, I think we have seemed to have lost Mike. We're working on getting him back. Maybe I'll just introduce him then while we have a moment here. So we're going to hear next from Dr. Mike Frigursky from VISCAN and UBC Okanagan. And he's presenting work called Model for Injury Reduction in ACL Miracle.ca. So we'll just pause for a second. Okay, actually, we're going to do a quick, let's see. Okay, we're going to give everybody a 5-minute break. So we're going to come back at 10:20, and hopefully we will have tracked down Mike, and we'll start again at 10:20. So 5-minute break. Thanks, everybody. Okay, welcome back, everybody. We are going to go to Raylene Marceau from UNBC, and Raylene is going to present work called Critical Analysis of Nurse Practitioner Funding Models. Over to you. Thank you.
Can you see that okay, Brenna?
Perfect. Yep.
Good morning, everyone. My name is Ray Marceau. I am a family nurse practitioner, actually currently practicing in Alberta, but transitioning into BC. I just became licensed in BC, and also an assistant professor with the School of Nursing at UNBC. So the title of my presentation today is a critical analysis of funding and compensation models, sustainability of the nurse practitioner role in Canada. And I'm just going to move something so I can see the rest of my screen here. I have no funding to disclose, and I just briefly wanted to acknowledge that I am joining you today from the beautiful but very chilly Fort St. John, which is the ancestral home to Treaty 8 territory, the land of the Beaver, Cree, and Denizah people. I wanted to quickly acknowledge the research team on this research, Dr. Tammy O'Rourke, Dr. Stephanie Montesanti, and Dr. Kathleen Hunter, all from the University of Alberta, and they participated with me in this research. And I'm going to try to very quickly go through this in about 10 minutes. Very quickly, this research obviously is about the nurse practitioner role and how we can better sustain it in Canada. The role actually has been around for about 40 years and has had quite a chaotic history. And it really made a resurgence in the 1990s and 2000s with primary healthcare reform. Nurse practitioners in Canada, if you don't know, actually have to have a minimum master's level preparation, and a growing number actually hold doctoral degrees. And all Canadian jurisdictions, provinces and territories have legislation and regulations supporting the role. Interestingly, the number of nurse practitioners has grown quite substantially across the country. I think we probably have about 7,000 or 8,000 across the country. The majority of these are actually located in Ontario. So although the number is increasing, the ratio of nurse practitioners to citizens remains quite low, only 14 nurse practitioners per 100,000 in the population. And really what we know is that the number is insufficient to meet the growing needs of a nation's population. There are considerably less NPs practicing in rural and remote areas of the country. No surprise there. One of the biggest challenges with the nurse practitioner role is actually sustainable funding and creating adequate infrastructure and resources in order to support the role going forward. A lot of individuals actually don't know that nurse practitioners are not funded the same as physicians and as registered nurses, and they are not funded out of global health budgets in provinces and territories. The objectives actually of this research were to create a comprehensive review of the funding models for nurse practitioners in a wide variety of healthcare settings. And we wanted to actually compare and analyze the funding models across all Canadian jurisdictions. Very briefly, I want to just describe what a funding model is. So typically a funding model has three defining characteristics. It generally revolves around a primary source of funding, such as governments or organizations. And within this primary source of funding, there are decision makers. And these are the individuals who actually dictate the flow of funds. These are generally government leaders. And it focuses on the motivations of the decision makers. So the party in power who actually control the flow of funds. So how this translates to nurse practitioners, based on this, an NP funding model actually involves the payment or remuneration for NP services or employment. And models across the country are actually based on numerous factors, which include base salary, bonuses, incentives, healthcare practices, and actually the individual team employment setting. Every Canadian province and territory has their own NP funding model. However, there are actually a number of significant variations in the defining characteristics of these models. And we actually think that's a good thing, and that these variations might be necessary to accommodate the wide variety of geographies and patient populations that nurse practitioners are working with. The majority of Canadian nurse practitioners are funded either directly or indirectly by provincial and territorial governments, and these funding models are structured to comply with legislation and regulations set out by the province or territory. Most NPs are funded indirectly through the use of government money, which is dispersed to an organization. So, for example, in BC, the money is often dispersed to a healthcare authority, a primary care network, or a healthcare agency. And NPs in these organizations are typically employees and receive hourly wages or a salary. Interestingly, across the country, a wide variety of government funding envelopes, we call them special type funding, have been introduced to support NP role implementation. And the issue with these funding opportunities are they're often pilot initiatives, and they're driven by perceived and actual physician shortages. So what's happening is nurse practitioners are often being used as sort of physician gap fillers. There's relatively few Canadian NPs that are employed by private or nonprofit corporations. And there's very few NPs in Canada that are actually self-employed, and these NPs receive funds from direct billing of patients. Now, interestingly, if these patients go to reimburse through an insurance company, there are sometimes issues with insurance companies still recognizing nurse practitioners as being providers. There are two jurisdictions in the country right now, British Columbia and Alberta, that have recently introduced since 2018 and 2019 allocation of funds for NPs and to create new opportunities for NPs to be part of team-based care. And this is generally through primary care networks in both provinces. The most innovative NP funding model is actually found in Ontario, where they do have the most nurse practitioners. And this is called the NP-led clinic model. And this is a model where the NPs are actually the leaders of the clinic, meaning they are involved in the board and the day-to-day managing human resources functioning of the clinic. But they actually work in the clinic, and the clinic actually employs an interprofessional team. So Ontario is the only province that's using this true interprofessional NP-led model. So what does this all mean? We know from doing this review that current nurse practitioner funding models are generally very rigid, inflexible, and they're often not based on evidence-informed policymaking. And they also perpetuate sort of these entrenched health policies that continue to really inhibit solutions towards addressing sustainability of the nurse practitioner role. Current funding models, as well as NP compensation, wages, and benefits, are really not keeping up with market value. And organizations with hierarchical infrastructure that support physician-led teams have total decision-making authority, and this often negatively impacts NP role utilization and optimization. There is a complete lack of transparency in NP workforce information, deficiencies in NP resource strategies, and no coordinated national NP workforce strategy. And lastly, and maybe more problematic, is there's a lack of innovative interprofessional models such as the NP-led clinic across the nation. So as far as future directions, the first direction is considering funding reform, and provinces and territories must really transition to evidence-based flexible funding models that support primary healthcare environments and variations in NP practice. And really, there's a very urgent need to amend and align Canadian national and provincial health policies to facilitate the transformation of NP funding models. There's equal need to actually enhance and harmonize what's happening for NPs as far as salaries and benefits across the country. And really, we need to start increasing the representation of nurse practitioners in currently underserved rural and remote areas. As far as interprofessional teams, we need to, despite the fact that there's a lot of research being done on interprofessional teams, there's still not across the country a lot of interprofessional teams that are utilizing nurse practitioners. So we need to expand the role of NPs on these interprofessional teams. And we need to facilitate the adoption by policymakers and funders of sort of multiple flexible, innovative funding models. And we need to consider the influence of existing policies on the success of these interprofessional collaborative practice models. As far as future directions on a comprehensive workforce strategy, we need to implement a comprehensive human health resource strategy that optimizes the use of Canadian NPs. And this is a strategy that needs to happen for all of nursing, not just nurse practitioners. And we need to have health human resource planning that doesn't necessarily focus on individual healthcare professional groups, but rather takes into account the integrated interprofessional team approach. Implications for research. Well, of course, we need to do more research on all of this. There was so much cross-jurisdictional and variability that we really need to do further work to understand these trends across Canada. We need to do a lot more research related to NP funding models in all settings to really show the impact of these models on sustainability of the nurse practitioner role. And we need to do more research examining interprofessional integrated funding models and the effects these models have on patient access, patient outcomes, and quality of care. The information that was collected and reviewed for this review actually was quite difficult to obtain because often nurse practitioner workforce statistics are buried within registered nurses information. And so we actually need to have better ways of pulling out that data and representing that data rather than burying it in RN workforce data. We need to do further research on NP funding models that rely on detailed, transparent workforce data, and we need to really monitor and compare what's happening across jurisdictions in Canada. In conclusion, this research was really intended to help improve our understanding of NP funding models in Canada. We have a long ways to go. This research really proposes improvement of NP optimization by employing modern, flexible, interprofessional, and integrative models that really reflect community health needs, patient needs, and the broad variety of NP practice. And we want to be able to conduct further evaluative research on current NP funding models and begin to build a robust NP workforce strategy and workforce network. Oops. And that's it. Thank you.
Great, wonderful work. Thanks, Ray. Let's see if anybody has a question. Maybe I'll just start. A quick question. What would be your number one recommendation? And what do you think is the most effective way of capturing some of this data? And do you go through gray literature, white literature? Are you talking to knowledge users or holders? Like, how do you really collect this information and survey such a dearth of information across the country?
I think that's a great question. And I'll go back to your first question, which was where would we start? And I think from a very global level, start working on, I mean, it really goes back to the very basic Canada Health Act and some of the wording. It's a very outdated and entrenched act and has created a lot of, outdated and entrenched health policies. So I would say from a very global perspective, we have to be doing research like this so that we can impact the policymakers and the people and the governments so that we can begin to change at a very fundamental level, the Canada Health Act. So I think from a global level, I would start there. As far as data collection and workforce data, I was pretty shocked actually by how difficult it was, even within our own professional organizations, to gather workforce statistics. And we were often told, even from our own professional organizations across the country, you have to pay, $1,000 in order to get this. And so really we need to probably create, and this is for all of nursing, not just nurse practitioners, a nursing national workforce database where we're tracking this information and a national workforce strategy. I think we probably start there. I don't know how to, address the situation of data just not being transparent and so difficult to find. And I think that probably does impact how we're recruiting and retaining nurses across the country, not just nurse practitioners. So I guess I would start there. We really have to focus on this human resource strategy and nursing workforce strategy.
Tracy Morton has a question about what is the optimal number of nurse practitioners in Canada?
That's a great question. I had read a statistic that family physicians, there was 224 family physicians per 100,000 people in the population. And I can't remember where I got that from now. And then when you think there's only 14 nurse practitioners per 100,000 people in the population, I don't know. And I think that's a great question. And I think probably that bears further research, right? What would be the ideal number? And I think that depends on what location you're looking at. Are you looking at urban? Or are you looking at rural? Because, most of our rural and remote areas are so underserved by all healthcare professionals. I would think that probably concentrating on those areas first as a workforce strategy, and maybe understanding what an ideal area is in our more rural and remote locations, and then branching out into our more urban areas. But that's a great question. I think that probably bears, that could be a future research question as well. I don't know whether I have an answer to that, probably more than what we're, for example, in Northern Alberta, in the area that I work in, I'm the only nurse practitioner for 30,000 people in the large catchment area, right, in Alberta. So I guess that gives you a bit of an example. There probably should be a few more of us.
Yeah.
And we're incredibly short of family physicians in that area too. So, globally, between family physicians and nurse practitioners in our rural areas and remote areas, it's an issue.
Great. And I'd love to talk to you more. We're finding that I'd love to know where nurse practitioners are going to for their education. De facto, we seem to be, I think there's about 650 in British Columbia, and we have about 1,000 in our database interested in education in primary care spheres. And I think it's unintentionally, we've been filling a bit of a gap for nurse practitioners for continuing education. But this is such great work, and maybe we can connect a little bit more, Ray.
Absolutely.
So thank you.
Yeah, that's wonderful. Thank you. Thank you, everyone.
Okay, we're going to go next to Dr. Mike Figurski. Thank you, Mike, for being here. I'm really glad I didn't have to present myself on ACL injuries. It would have been a disaster. So representing Viscan and UBC Okanagan, Title of the talk is Model for Injury Reduction in ACL, miracle.ca. Over to you.
Thanks very much, Brenna, and thanks for filling in, Ray. The irony isn't lost on me. I'll share my screen on our project. I was fortunate enough to get some funding through the Faculty of Medicine UBCO to look at a problem that's vexed me here up at Big White over the last 23 years. I'll just give you a shot outside. We've got tons of snow. If any of you guys are skiers, it's a good time to come up before the kids get out of school. Surprisingly to me, women are 5 times more likely, women and girls are 5 times more likely to suffer an ACL injury per hour of skiing than men. And there's a lot of factors for this, and we won't get into that today. But we did assemble a group to put together a project to look at a plan or program, open source and free, available here in the community that we can use to try to reduce these numbers for men and women, particularly in skiers and particularly in young skiers. Night skiing is resumed this year at Big White, so they're going to start the after school programs again with kids coming up. They get 3 free trips or 3 trips in grade 5, including rental and instruction with a bus back and forth. And so that would be a great time for intervention. What we put together a great team this summer. Anthony is a student from UBC in microbiology who designed the website and did some literature review. Rama is from Alberta and taking microbiology there. She helped us with the design project implementation of the physical program and the brochures and resources. Deb is a PhD candidate at UBCO in artificial intelligence that did our IT support work. There's a team there. That's us at the field at Big White doing the PEP program on our own. So we looked at the literature and found out there was actually quite a body of knowledge that reflects positive outcomes from pre-injury interventions, some of them quite minimal. There was a study in California on female soccer players, 10,000 of them going to a tournament, when they showed them a 1-hour video on a bus. And surprisingly, statistically to 0.05, there was an 80% reduction in ACL injuries among the group that watched the video versus the control group that didn't, and everything else was the same. Now, how many goals that cohort scored is another question, and whether it affects their behavior. The video they had reminded me a lot of the video you'd get learning to drive in high school, where it was mostly about some really bad outcomes. More, there wasn't a lot of rehab or preparation offered. So one of the interesting parts was going through the consent as a mock exercise, going through the consent and ethics committee review process with the help of the staff from UBCO here in Kelowna, which was very instructive for me. I was surprised that there were so many resources to help me through and the students through what would have been an application process actually if this study had commenced. We haven't started commencing yet. We're using 3 recognized, proven, accepted prevention plans, integrating into one program, and we're allowing patients to access them freely just to become more familiar with the nuts and bolts and pragmatic implementation of these interventions. So this would be the flow board. They register. We do a pre-risk assessment. We've got a medical student now. Nicole Watt is here on Monday afternoons, helping to screen patients and working in our knee clinic here at the Stonebridge Clinic at Big White, which is more of a gym than a medical clinic. They'll watch the situation awareness video. They'll have a 12-week preseason exercise program 3 times a week. And then they'll do a LESS test, which is a validated risk assessment based on technique and body positions. Deb is involved in this. He's interested in this part. We're doing another project with the immersive technology at UBCO using VR and LiDAR technology to do pose estimation of what positions the ankle, knee, and hip are in during landing, and correlating it with expert position for ACL injury, and then seeing whether there's any models that predict well which, at this point, which people are felt to be high risk based on video from the side and front. So they created some brochures and information on what the program implements, the PEP program. We applied through WorkSafe BC, hoping to get funding to implement this on a larger basis rather than just one afternoon a week. There was some interest, but we haven't found a sponsor yet. There are some resources. The website is a little pretentious, but I understand that's not uncommon in the industry. So it's medical interventions to reduce ACL injury, miracle.ca. And any of the resources we have here are all free and open source, and you're welcome to borrow any of them for any kind of testing or training you're interested in your area. A little bit about the program. The most interesting part to me was the risk assessment. This is done pre-program and post-program to see whether or not the intervention actually had a measurable impact on these parameters of joint position as measured by Pose Estimator, an open source pose indicator. The way this program works is they jump off a 30-centimeter block onto the ground, compress, jump up again, and land again. And then people with no specific instruction are asked to grade whether, but they're all experts in the field, either a level 4 instructor, ski or snowboard, or whatever the sport may be. And they give an opinion on whether or not that person's at risk of an ACL injury. And certain positions certainly are associated with it. Anytime you have your knees over your toes, anytime there's any asymmetry in the sagittal plane, anytime when you land, when you jump and come back down and you're not on balance. Obviously, you weren't on balance when you first landed. These are the things we're going to be looking at, describing machine learning models to see whether or not the numbers in the poses show any insight into what is the most risky positions. We hope to do what would be the equivalent of a phase 1 trial this winter, just having the resource open, allowing people to freely use the trial program. It's been posted to Facebook as a free drop-in session on Mondays for anyone who's interested in reducing the risk of ACL injuries. I should mention the impact from a workplace standpoint. 10% of the 100 professional ski and snowboarders, mainly instructors and patrollers, are injured every year. So that's a tremendous blow to the workforce, not to mention all the other employees and workers up here who are likewise at high risk. And it's not just a career, or not just a season-ending injury. For most of these people, it's a life-changing one. And that was it.
Thank you. Very interesting. I just got an email from WorkSafe BC about a call for research grants. I popped that to you in the chat.
This is already paying off.
Yeah, let's see if we have any questions here. Maybe I'll start. I am a skier. I'm depressed to know that I'm 5 times more likely to tear my ACL than my husband. And we live at Whistler. That's where our home is. So a question for you: what would I see in the awareness video? What would be some of the messages? Is it about just skiing, proper skiing technique? What are the things that I would see, Mike?
There are 3 common ways to have an ACL injury, and by far the most common one, and the one that people are often unaware of, is positional impact. I used to coach my younger sister's basketball teams for years, and it was one of the first things we tried to teach them was how to land, because I found that a lot of the women and girls tended to land with their legs extended in knee position, and that's probably half of the ACL injuries I see in especially younger women here is they take a little bump. It's nothing. They land and they go forward, and then suddenly their knee, it doesn't hold anymore. So one thing I'd first instruct every skier to do is to learn to compress, rather than to try to land with a stabilized knee. You want to land soft like a ninja. You don't want to make any sound when you land. You want to land with both legs impacting around the same position and time. Other common injuries are where people try to hold on too long. A lot of the time, the ACL injury occurs on the uphill ski where you're making a turn that way and it gets caught, and you try to hold it until it's too late, and then you fall forward, and the combination of external rotation and valgus strain on the knee gives you the triple injury of an MCL, a medial meniscus, and an ACL injury. Those are the two most common mechanisms. And the one that's entirely preventable that I see in kids a lot, men and women, or boys and girls, is riding on your boots. Very vulnerable position.
Great, thank you. I had a friend that was a surgeon, and he always opted for skiing because he said if he tore his ACL, which was more likely compared to snowboarding, at least he didn't break his wrist and could still work. So very interesting, very relevant. Thanks so much, Mike.
Hey, my pleasure. I came from Winnipeg, and they called us ditch skiers because the biggest vertical drop was about 120 feet outside of town. And I did the same. I'm a snowboarder here for that reason, because you can still work with a dislocated shoulder.
Yep. Okay, wonderful. We're going to go to Emily Boardman next from the Division of UBC Continuing Professional Development. And Emily's going to present work titled Rural Physician Thriving, supported through UBC CPD.
Wonderful. Thank you so much, Brenna. Yeah, thank you for having me here today. My name is Emily Boardman, and I'd like to acknowledge that I'm calling in from the traditional and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh Nations here in North Vancouver. I'm an education manager at UBC Continuing Professional Development, and today I will review my Engaged Leadership project on rural physician thriving, which I completed in partnership with UBC CPD as part of my Master's of Arts in Leadership through Rural Roads. So today I will review a little bit of context of rural physician thriving, my inquiry questions, and share findings and recommendations. So as we know, the last couple of years have been demanding for frontline workers, resulting in incidences of higher stress, burnout, exhaustion, and other personal and professional challenges due to the impact of the COVID-19 pandemic. The Canadian Medical Association Nationals Health Physician Survey shared that 53% of respondents reported symptoms of burnout. So through my research, I really wanted to contribute to finding some solutions to the current challenges that rural providers face by speaking to rural physicians as a first step here in BC. So my research question was, how might UBC Continuing Professional Development further support rural physician thriving? Sub-questions explored what motivates rural physicians, how they describe rural physician thriving, stories they have about thriving in rural healthcare context, and what changes could be implemented to achieve rural physician thriving. So my hope was that through this research, I could create change in the rural healthcare context by exploring additional opportunities for physician thriving and positively impact the well-being, patient care, and health services delivery. I thought a good place to start would be to speak to rural physician leaders and coaches because they understand the rural landscape well. They have strong relationships across BC. They often work with numerous organizations as consultants, and they're really knowledgeable about resources and supports for rural providers. So in total, I engaged 13 rural physicians to generate qualitative data. I completed 6 interviews with members of the UBC Rural CPD Medical Advisory Committee and 1 focus group with 7 UBC CPD medical leads and experienced coaches. Also, I'll go through my findings and provide a little bit more information about those. Number one, my finding was rural physicians are motivated by the challenges and joys of rural practice. So a lot of participants spoke to the challenges as working as a family doctor in rural practice as never dull. It's dynamic, exciting, intellectually stimulating and challenging while also being recorded. And many use the terms to describe themselves as lifelong learner, inquisitive, adventurous. And they also spoke to the joys of having something worthwhile to contribute, a valuable service, and also connecting with diverse individuals and working in teams as well. A key attribute of rural physician thriving is effective and individualized support for one's colleagues, community, and healthcare system. Participants highlighted the importance of having a strong connection with colleagues within and outside their community. So numerous participants described receiving support through backup. And they use that term in particular to receive a second opinion or offer advice or encouragement, or even share the responsibility of burden of their decisions. They spoke to the community. Support includes having friends and families outside of their colleagues with whom they could be social with. And then support from the greater healthcare system, including provincial policymakers, health authorities, regulatory bodies, educational institutes also affected physician thriving. Number three, there's an interdependent relationship between rural physicians, patients, communities, and healthcare systems' ability to thrive. Research participants shared that it's the physician-patient community or healthcare is struggling, it will negatively impact the other parts. So one participant even said the vibrancy of community is directly related to the emotional and physical health of physicians and other healthcare providers in that community. I thought this was also relevant when they highlighted that having a natural environment enabled them to thrive, which is becoming more important as we face the effects of global warming and climate change. And barriers to rural physician thriving, included an urban-faced healthcare system, a healthcare culture which encourages heroism, a lack of resources, primarily due to staff shortages, pay imbalances, and awareness and access to support. So healthcare in BC tends to be urban focused, especially through medical school, they highlighted, because it's often taught by urban specialists. And participants identified attributes of the healthcare culture that affected physician thriving were heroic behavior and ignoring one's own needs. And then also a lack of resources came up as a barrier, such as staff shortages, which was aggravated by a lack of time and pay imbalances, rigidity, and lack of awareness of supports. And that work-life balance was really important to them as well, and having that time. Just jump into the recommendations. So for the recommendations part, I did focus on recommendations for UBC CPD. However, a lot of the recommendations that were identified could also be applied across other organizations as well. So many said that UBC already confirmed innovative education from a ground-up approach and opportunities for collaboration and partnership with credible experts. They're a key driver of physician thriving. So the first recommendation here is broaden deep listening of holistic community and physician needs. So to further assess and understand the challenges, needs of rural communities and physicians, staff may engage more in deep listening, perhaps being more knowledgeable and curious about the needs of the community based on geography, culture, demographics, patients, desirable skill sets of the team, number of healthcare professionals, and more. Strengthen the healthcare culture by advocating for the holistic needs of rural physicians and rural generalism with other healthcare organizations. So UBC CPD staff are well positioned to continue to advocate for rural physicians' need and work towards strengthening a healthcare culture that encourages openness and learning. So such advocacy with health authorities, regulatory bodies, and the Faculty of Medicine may lead to system level changes. And foster relationships among peers, interdisciplinary teams, allied healthcare professionals to strengthen support and encourage shared responsibility. Recognizing the benefits of having a strong relationship in the medical system, UBC CPD could further support rural physicians by continuing to foster strong relationships between peers, interdisciplinary teams, and allied healthcare professionals. And 4, expand educational opportunities and support to develop rural physicians' power skills. So power skills are also referred to as soft skills and used regularly. So research participants expressed that having strong communication skills to build relationships with their patients, teamwork skills to collaborate with their peers effectively, coping skills to deal with challenges and traumatic events were important to their well-being and success. And they emphasized that strengthening power skills in medical schools or earlier practice will support physicians in navigating the complexities of their role and encouraging well-being. Final here is assist communities and individuals to navigate and safely access supportive resources. So research participants mentioned that to support physician thriving, additional assistance could be offered to rural communities and individuals so they can more easily navigate and access these supports, especially engaging those who are not currently being supported or aware of these resources as well. Well, yeah, thank you so much for having me. I really enjoyed this project. It was a great opportunity to hear from and speak to and amplify the voices of rural physicians to enable change. And I want to thank everyone who took part in the survey or took part in the research, and also UBC CPD for supporting me. As a next steps, when I completed this in the summer, I have shared my recommendations and findings with UBC CPD and RCCBC, and I understand also the Joint Standing Committee. So if anyone would like to discuss this further, please reach out, and happy to take any questions now as well.
Thanks, Emily. That was great. I'm going to just pause for a second here and see if we have any questions from the gallery. Okay, so maybe I'll just start off with a couple. This is such great work. I think the timing of this is so interesting and so fortuitous. Question: has this been shared with Physician Health, the Physician Health organization? Maybe I'll start there, and then I can ask you another question after that.
Yeah, for sure. I've shared it through the RCCBC, as well as I did a bit of a focus group with some of our clinician leadership team, which was quite fun. So we have a coaching and mentoring team that gets together once a quarter, and we are able to discuss and review these findings as well. So there may be an opportunity to share with more Coastal Health, which I think would be really interesting as well, sharing with other health authorities. But that's kind of the scope for now.
Great. Yeah, I think this would be great to make sure it's brought to I think Physician Health program would really love and would benefit from these results. One of the most interesting things about your finding is that interdependent relationship. And I wondered if you could just speak a little bit more on that, because I think it's very, very interesting. Yeah, I'd love to hear more on that.
For sure. That was something that actually surprised me a little bit about the research too. I think, when I heard it from perhaps almost every participant that was an important piece of what they're doing, it made sense in my mind, but it's not something I'd thought of as an education manager and programmer for many of our supports until I'd sort of heard stories and examples. And, I think it really makes sense where people would speak to how, the community is so closely connected, especially within smaller rural communities where your neighbors, and you might see that patient at a soccer game on the weekend or the ski hill on the weekend. And I think there's a tie and connection within communities that's so special, and that doesn't leave them on the weekends or at work. It's sort of tied to their being. A couple physicians also said actually that even at the grocery store, they answer questions from patients, and that they're in that rural physician role all the time. That's a big part of who they are within their community as well. And so I think that interdependence between the community's health of, how is the community doing? Are they fighting natural disaster? Are they, struggling with other things within their community? That's going to impact the patients, and that's going to impact the community, and that's going to impact the healthcare as well. So it's just, it was really, I really appreciated seeing that connection and hearing and learning more about that as well from the rural physicians.
Sorry, I'm on mute. That's wonderful. Thanks so much. If you were given a pot of funding to move some of the findings of this forward, what would you do first?
That's a good one. I think for myself, I had quite an interest. I do think I have quite an interest in the deep listening piece. I think that's something, the recommendation one, where taking a little bit more time to dig a little bit more deeply into the communities. And I know there's other programs and organizations where we could learn from. I know RCCBC does site visits, so perhaps an opportunity there for us to do more sharing across organizations of what is happening in each community and how can we support based on geography and demographics. So probably use some of that funding to do more traveling and connecting directly with the providers as well.
Great.
Say
Yeah,
the
and my-
second piece is, oh yeah.
Yeah, go ahead.
I was going to say the second piece that pops up is definitely the relationships among peers. I think if there's opportunities to bring people together, like this conference, and to support that interdisciplinary team coaching as well in any different ways, whether it's social or professional, that was something else that was highlighted where that could really help strengthen the community and strengthen the team.
Wonderful. And then the last one, your thoughts on, I really love how you've taken this from a bit of a positive angle around thriving over burnout. Can you provide a little bit of context why you decided to go kind of from a positive angle instead of from a deficit angle?
Yeah, totally. For the first year of my master's, I was quite entrenched in burnout and exhaustion, and I was doing lots of research around those topics. And there's a lot out there, and I think there was some great learnings. And then it was through sort of the Royal Roads education and just learning more about appreciative inquiry that really interested me in sort of switching that lens. I also had my advisor for the master's project was an appreciative inquiry researcher. So he's put out a lot of articles and journals about appreciative inquiry. So he was someone in particular who sort of said, had you considered this or thought of this? And then when I went down that way of, focusing more on physician thriving, it just really opened the door to learn about what is working and how can we foster and nourish what is working for folks. Because some of the people I spoke to said, yeah, I am thriving and I am currently flourishing, and this is what I'm doing, versus others sort of said this might help me to get to be a thriving rural physician. I really liked that lens and appreciated it throughout the whole project.
Great. Thank you so much, Emily. It's wonderful work, and thanks for sharing.
Thanks so much,
We're going to go next to Juliet Oshiro. The title, affiliations are Rural E-Mentoring and UBC, and the title is Using Online Mentoring to Support Rural Student Pathways to Healthcare Careers. So over to you, Julia. Thanks for sharing your work.
Hi, everyone. Thank you so much for letting me come here today. I run a mentoring program for rural youth called Rural E-Mentoring BC, and I'm the project manager, and I'm just here to share some of what we found. But before I begin, I'd just like to take a moment to acknowledge that I'm coming to you from the traditional, ancestral, and unceded territories of the Musqueam people, what's now known as the UBC campus. And I'm really grateful to be able to do all my work here. Okay, so some background about the project. The need we are addressing is, we all know that there's a shortage of rural healthcare practitioners, but we also know that many students, rural students who pursue healthcare careers will often return home to practice. So we can logically think that maybe by increasing rural student enrollment in healthcare programs, we can address some of these shortages. So the principal investigators on this project developed an online mentoring program, and just to see if it would support rural student pathways to healthcare careers. So in 2016, Rural E-Mentoring BC was developed. It was started. It was started at UBC by Dr. Sandra Jarvis Selinger and Catherine Weisner. And then we went to the Rural Education Action Plan for funding. And Dr. Blair Stanley has been our champion over there. So how the program works is each student gets matched to their own mentor. And all of our mentors are post-secondary students studying somewhere at a college or university here in BC. And we do our best to match them based on compatibility. So our priority is to match them based on their career interests, especially if they're interested in healthcare careers, but we also take into account things like experiences, hobbies, whatever the mentees think, ask us that they want about what they want to get out of a mentoring program, just so that they can build that trust and try to get them to share. They communicate via asynchronous messaging through an online platform called Mentor City. They just write messages to each other. And the program's structured around a semi-structured curriculum of 12 modules. And the modules are all about preparing for life after high school, the transition from post-secondary, from high school to post-secondary. So things like career exploration, learning about different schools and programs, and then things like finding your place in the world. So like confronting discrimination, well-being, stuff like that. And we designed the program to be flexible. So teachers can use it for course credit in their classes, and then individual students can just sign up and do the program on their own. So the way we've evaluated this is we have voluntary surveys for all of the participants. Of course, we can't make it mandatory, but yeah, they do a survey before the program and then after. And so what we found, just in terms of numbers, the first 3 years of the program were pilot years. But then after that, we've grown pretty steadily. The number of schools has increased, and then the number of students participating has increased, except for this hiccup in the COVID year. Most students participate as part of a class. And you can see that most students are participating in grades 10 and 12, which is when they have their career life education and career life connection classes. So the impact that the program is having on students, ask them about their interest in healthcare careers before and after the program. And we actually found that more students were interested in healthcare careers after the program, which is really encouraging. So, this suggests that students became interested in healthcare careers during the program. We acknowledge that our sample sizes are low because of the surveys are voluntary and we might have some selection bias. And these are just from the pilot years, and we're still kind of working on the past couple of years incorporating those, but it's pretty encouraging. We also had students just in short answer question format tell us what they found helpful about the program. And their answers kind of shook out into 4 different categories. So first category was about their future careers. So they enjoyed learning about their different career options and what to expect in those careers. Second category was post-secondary. They enjoyed learning about the different schools and the programs and what they had to offer. And then they also just enjoyed learning, just gaining knowledge and getting all that information, asking questions about program requirements, scholarships, and then what to expect when they get to post-secondary. Life skills was the third category. So things like financial help, that was a really popular. And then even things like considerations of privilege and equality. Students told us that they got that out of the program, which is really awesome. And then they also learned how useful it is to have somebody there giving you feedback. And then the students really, really liked their mentors. No matter what they thought about the program, they all loved their mentors. They enjoyed hearing their mentors' views and opinions, and just having someone there to ask help from. Some of the challenges we came up against, of course, tech things. So teaching users how to use the platform, navigating tech glitches, Keeping students engaged. So, students really like the program, but, they're busy high school students. So how do we get them to respond regularly, complete the curriculum, which kind of leads to the next thing, which is like, how do we make the program useful and how do we make it a priority for students when they're so busy and have so many other things competing for their attention? While also balancing our stakeholder needs. So like, the needs of the students versus the needs of the teacher versus what REAP wants. So in conclusion, I think the program's been pretty successful, and the youth who participate in it really enjoy it. They find it helpful, which is really encouraging. But if you take anything away from this talk, it's that you should go talk to the youth in your community about healthcare careers, and we can help you do this. So we have what's called the Pathways to Medicine presentation, where we can help you give a presentation to your local youth about pathways to medicine. You can just be a mentor to the youth in your community. If you're a student, you can volunteer with us and be a mentor. If you're not a student, you can still be a good mentor. All you have to do is just be available to chat, or maybe offer some shadowing opportunities. And if you're totally not comfortable with any of those things, but you still want to help youth in your community, you can tell them about us. Ask us for like a flyer or promotional materials, and we'd be happy to help you out. And so that's my contact information. If you have any questions or want to reach out, I hope you do. That's it.
Great. Thank you, Juliet. That was a great talk. And thanks for sharing that really important work. Maybe we'll just see if anybody has some questions here. So I'll start off, and then please just add your question to the chat if you have one. How many, a question, longitudinal, do you know if they still have relationships with Mentor, and maybe the ones from the 2016 data, do you know if they are on pathways to careers in healthcare? Like, do you know anything about what's happening over the long term with the data?
Yeah, that's like always the question everyone asks, but it's like notoriously really difficult to track, minors, especially, once they graduate. We are trying to, strategize ways to get those data. We do have a couple pairs that like continue on voluntarily. We have a pair that's been going for like 2 years now, which is really cool. Yeah, so the answer is like, we don't know, unfortunately.
A typical question, and thank you. That's it. I think it's a struggling one. Very interesting. Do you know anything about if the conversations between mentor and mentee, if anything's covered on like the practicalities of like life and being a healthcare provider or professional? Has that come up in the data?
Yeah, so we have a whole career exploration unit that they can do, where we like encourage them to ask those questions. And the mentors are pretty open about sharing these things, and they do have some really good conversations and really good sharing, and yeah, it's a really good way to like impart that information.
Great. Maybe the last question then is the recruitment all done through these high school programs? Is that how you get the mentees into the program, and how do you recruit new mentors?
So on the mentee side of things, the most like the way we found that's easiest is to get them is to go through the schools. But we've also tried to reach out through like youth centers and social media, whoever will talk to us. And then for mentors, we usually go through like post-secondary schools. We post on like the volunteer boards. We reach out to the different departments, and yeah.
Well, thank you. Maybe one more thing that I would ask you. Can you tell me a little bit more about, so are they actually, you talked about the Mentor City, is it done through chat? Do they set up phone calls, Zoom? How are they connecting kind of on that for questions?
So they type messages to each other. There's like a little send message box, and they write their message and click send, and it's all there. Yeah, and just because they're minors, you know, we can't really have them like video chatting off on their own without us being able to see what's going on. But yeah, it's been really nice to see that even though it is asynchronous communication and just written messages, the students, like, they'll open up, and it's really cool to see. Yeah.
Wonderful. Okay, well, thank you. Maybe just pause for a second if anybody has a quick question. Okay, I don't see anything. Well, thank you, Juliet. This is wonderful work, and certainly Blair and Catherine and Sandra are great advocates and do wonderful things. Really interested in the research, so that's great. Thanks for sharing your work, and I'm glad to see this program has been so successful.
Thanks. I'm sorry, I'm trying to get the little, oh, here it is. Sorry. Okay. There we go.
Okay, let's see. I think we have Agnes and Surya. So we have Agnes Ho and Surya Bondi from UBC, and they are going to present their work called Implementing an Adolescent Sexual and Reproductive Health Education Program in Rural Nepal. Over to you two.
Okay, hi there. Sorry, guys, I was just figuring out my presentation slides. It's nice to meet everyone. My name is Soraya. I'm a second-year medical student at the Island Medical Program at the University of British Columbia, and I'll let Agnes introduce herself.
Hi, everyone. My name is Agnes, and I'm also a second-year medical student at the University of British Columbia.
All right, so today we're going to be talking about our project, which is the Nepal Sexual and Reproductive Health Project. So it's not necessarily rural BC, but we are working in rural Nepal actually instead. So I wanted to give a quick land acknowledgement. I acknowledge and respect the Lekwungen peoples and the Songhees, Esquimalt, and Wassanic peoples whose historical relationships with the land continue to this day. I'm very grateful to be living, working, and playing on this very beautiful land. So our project takes place in the Dang district of Nepal, which is in the Terai region, which kind of lines the southern border there close to India. And we specifically focus on the Tharu peoples who are indigenous to the Terai region. Historically, unfortunately, the Tharu people have belonged to Nepal's lowest caste, and through the Kamaya and Kamlari systems of bonded labor, girls and young women were commonly sold by their parents into indentured servitude until around the early 2000s when this became illegal. These practices have had really long-standing impacts on women in these communities, and many families are unable to provide their children with sufficient educational opportunities. And this has, of course, led to a perpetual cycle of poverty. So we work with a nonprofit organization in Nepal called Creating Possibilities. They work very closely with the Tharu communities in Dang to provide educational opportunities to marginalized youth and women through delivering classes, creating scholarship programs, and building community centers and classrooms. The UBC partnership with Creating Possibilities first began in 2015 with a sickle cell disease screening project because sickle cell disease is very endemic to that region. And then in 2020, CP approached us with a new area of need that they felt we could help out with, and that was adolescent sexual and reproductive health. And so that led to the creation of this project, the UBC Nepal Sexual and Reproductive Health Project. So the overarching goal of this project is to address sexual and reproductive health barriers through empowering and educating adolescents in rural Nepal. Our goals include basically developing an in-depth understanding of sexual and reproductive health, knowledge, attitudes, and services in Nepal, identifying barriers to accessing sexual and reproductive health services and education, specifically in Dang, and creating and implementing a comprehensive and culturally appropriate adolescent health education program there. We also wanted to collaborate with local Nepalese organizations to optimize the services we would deliver to Tharu communities. So there were 3 components to our methods. The first was that we conducted a comprehensive literature review and a needs assessment to identify gaps in Nepal's sexual and reproductive health curriculum and available services. We also engaged with local organizations involved in sexual and reproductive health to share resources and ensure that community needs were being addressed appropriately. And then finally, we developed a culturally sensitive educational program, which local educators are now using to provide comprehensive sexual and reproductive health education to growing numbers of adolescent girls in Dang. So right now we have over 450 girls participating, which is really exciting. And so from our literature review, we found that adolescents in Nepal are more vulnerable to gender inequality, child marriage, domestic violence, unwanted pregnancies, and non-consensual sex. And although the Nepali government has implemented sexual health into the school curriculum, the current education is unfortunately vague and age inappropriate, and it doesn't meet many of the attitudinal and skills-based objectives that are outlined in the International Technical Guidance on Sexuality Education, which is guidelines created by UNESCO. So some of the major barriers to effective delivery of reproductive and sexual health education in Nepal are, one, unfortunately, inadequate training of teachers. And because of this insufficient training, teachers often don't feel comfortable discussing really important sexual and reproductive health topics. And this kind of feeds into our next point, which is traditional views regarding sex and gender roles. And then third is resource limitations, which are especially exacerbated in rural settings.
And so for the next phase of our project, we engaged with local organizations. So there are 3 Nepalese ones and 1 UK organization. And these are all groups that were already doing work in sexual and reproductive health education and advocacy. And our team met with these groups to talk about the gaps that exist in the Nepalese curriculum and also to expand access to currently existing educational resources. So for example, the organization UA had a lot of great materials that they'd already developed, which we collaborated with them on to develop our own materials for our program. And as the third part of our project, we completed our needs assessment and we found really interesting results. So we surveyed 100 participants aged 12 to 18 years old in rural Dang, and only 68% responded that they had learned about sexual health, and 63% knew how to prevent pregnancy. And as you can see here, 97% did not know how to terminate pregnancy, which is obviously very alarming, and only about half knew how to prevent STIs. So taking all of this information together and with collaboration with Creating Possibilities Nepal, we created the Adolescent Health Program. And so this is a series of 9 sexual and reproductive health education sessions created from existing literature and resources. And through collaborating with our partners, CP Nepal, we were able to make sure that this was culturally sensitive and appropriate. The topics covered include puberty, menstruation, reproduction, STIs, abortion, family planning, gender equality, and child marriage. And so this program first started in October of 2021, and it started with 3 groups of students. And now, as Saraya mentioned, we have over 450 students participating. And at first it was just in 1 municipality, but now there are 3 municipalities that are participating. And there has been lots of growing interest from nearby communities. And it's really exciting. Local governments and schools have expressed interest for more classes and groups to be made. So that's something that we're very interested in implementing over the next year. And in May of this year, our team was very fortunate to have been able to visit Nepal in May, and we actually attended some of these adolescent health sessions. And it was just really incredible to see the excitement of these girls and how engaged they were with the content and learning more about themselves and their bodies. During our time in Nepal, we were able to review the lesson plans and go through feedback with both the students as well as the educator in Nepal that we work really closely with. Her name is Sita. We also had the chance to discuss with local mothers groups and female community health volunteers about menstrual hygiene. So for example, we led a session about menstrual cups, and also about reproductive health in general. Another really key part of our visit was chatting with different physicians at varying levels of the healthcare system. So for example, those working at the local health post, and then in the smaller hospital, and then the major hospitals, just getting a sense of the kind of differences that exist within Nepal. So in terms of what we learned during our visit, we're really excited to see that the program has been very well received and there's lots of interest. When we talked to the students, we found that menstruation and pregnancy were the most popular topics, but others like STIs, abortion, vaginal health, and consent, the students found a bit confusing and they wanted to learn more about. We also saw through going to the health post that adolescent health services have not been really implemented or utilized in these rural settings. And even in the larger centers where there are services like pregnancy termination and STI care, people still aren't really accessing them because of those cultural barriers that Surya talked about. And just to highlight that point, we did notice great disparities in sexual and reproductive health knowledge between urban and rural settings. And so in terms of next steps, we currently are updating our lesson plans and creating new modules based on feedback from educators and from the students. We are monitoring the impact of our program through knowledge and satisfaction surveys. And we're also creating a training of trainers manual for future educators as our program continues to expand. And of course, funding is always important, especially as our program continues to grow. And so here are a list of our references, and we're happy to take any questions at this point. Thank you for listening to our presentation.
Thank you, Agnes and Surya. That was really, really nicely presented and such important work. Maybe we'll just pause and see if we have a question from the gallery.
Sorry, I just wanted to mention too that our initial seed funding to begin the program was actually from RGHPI. So we're very appreciative of that funding because that is what started it all, everything.
Great. We have a question from Kelsey. Kelsey, go ahead and ask your question.
Hi, thanks so much. What a great project and presentation. I'm curious, I might have missed this, so correct me if I'm wrong. Was the focus just on education for women and girls? Or I was curious if boys are included in the programming or if there is interest in that and maybe the decision around that.
Yeah, that's such a great question. Thank you, Kelsey. So yes, the initial program, and currently it is for young girls. But actually while we were there and based on feedback from our partners, we have heard that a lot of young boys are interested in the program as well. While we were in Nepal during some of the sessions, there'd be young boys like trying to like listen in as well. And they were very curious. And something that our entire team feels really strongly about, sexual and reproductive health applies to everyone, not just young girls and women. So yes, we are hoping to expand our program to young boys in the future, and that's what we're working on this coming year.
Awesome. That's great to hear.
I have a question for you. How were the surveys, how are the surveys distributed in terms of the needs assessment? And also, you said you're doing program evaluations. And my second question is, who are the teachers and how are they trained?
So the needs assessment was a survey that was created based on validated tools. And basically we disseminated that through our contacts in CP. So we created the survey and then gave it to CP, and CP is just very much involved within the communities there. They kind of have contacts with all the schools. They've built a couple of the schools. And so they just kind of handed them out to adolescent girls there.
So it's paper-based surveys?
Yeah, it was paper-based surveys, yes. And then in terms of program monitoring, that's something that we're really trying to optimize this year. Basically, we have knowledge surveys, which kind of look at knowledge uptake from beginning to end. And then we also have feedback forms, which give the girls opportunities to talk about things that confuse them. What did they like? What did they not like? What did they want more information on? And so those are given out after each educational session. So there's 9 right now. And then any additional questions will be addressed in the next session. But now we're kind of working on creating these Google Forms so that we can have all that information much more easily accessible to us, because right now we're just receiving scanned copies of all these feedback forms, which are in Nepali. So it is a kind of a barrier that we're trying to overcome at the moment.
And then the question about who are the teachers and how are they trained?
Yes. Agnes, do you want to take that one?
Yeah, sure. So our first educator, her name is Sita. She's actually local to Dang. So that was something that was really important to both us and CP because she is from the area. So she really has a good sense of the issues. And some of the girls that she's teaching right now are young girls that she grew up with. So that was really important to us, having teachers who are local to whatever area that they're teaching in. And she was trained in Kathmandu under an education program, and she applied to CP Nepal, and they went through an interview process there. In terms of hiring, like Surya mentioned, that is something, our entire program, CP Nepal is at the core. They really have the most say and insight into the programs and initiatives that are going on there. So they were involved in that hiring process. And in terms of training, she does have a background in education, but the sexual and reproductive health area, that's kind of where our team comes in to help fill in those gaps and direct her to the appropriate resources. Oh yeah, go ahead, Maria.
Oh, I was just going to say that they've hired 2 new educators now that they've expanded to 3 municipalities, and these new educators are from the health sector as well. And that's kind of in our next steps is creating the training of trainers manual so that it's very much standardized, the training that each educator gets. But so far, Sita has been kind of leading this program, and she was the one who trained them based on the resources we've given her. And those resources also, part of them came from YUWA, which is a Nepalese organization that has adapted sexual and reproductive health education towards Nepalese students.
Great. Thank you. Very interesting and important work. Thank you for sharing it today, and great job on all fronts.
Yeah, thank you so much, everyone.
Thanks so much, everyone. And I guess we didn't put our emails on here, but if anyone has any more questions, I guess we could reach out through Tracy.
Great. We can maybe have Tracy put them in the chat as well. Okay, we're going to go on to the next one. We have Nicola Vasinik and Danielle Cohen from UBC, and they are going to present work titled Improving Health Equity Through Rural Hospital Infrastructure Development in Northern Ghana.
All right. Hi, everyone. Good afternoon or morning. Our names are Danielle and Nicola, and we are 3rd and 2nd year medical students from UBC. We're presenting on behalf of Ghana Medical Help, and we're here to talk to you about our project on improving health equity through rural hospital infrastructure development in Northern Ghana. Ghana Medical Help is a non-for-profit Canadian charitable organization that was founded by Dr. Kelly Hadfield and Dr. Dominic Akataba that focuses on sustainable solutions to a broad range of global healthcare related issues in rural Ghana. So Ghana is a model for development on the African continent, yet it has been unable to meet the UN Sustainable Development Goals for health. Part of the reason for this is that Ghana exhibits significant regional bias in its distribution of health resources and personnel, with the urban south being relatively resource rich and the rural north being relatively resource poor. This is especially true for the health technology management sector, with clinical engineering departments at rural hospitals being severely underfunded. This has resulted in undertrained, under-equipped, and unsupported clinical engineers who are unlikely to remain working in the rural areas. This presents a very problematic issue as a robust clinical engineering department is essential for effective healthcare delivery, as it allows facilities to maintain functioning medical equipment. This becomes especially important in the context of medical equipment donations to healthcare facilities in resource-poor environments, given that these donations tend to have a limited lifespan without an efficient clinical engineering department. So with all that being said, our goal was to strengthen the local clinical engineering capacity of marginalized rural hospitals in Ghana's rural north. Since 2019, Ghana Medical Help has been collaborating with Ghana Health Services to strengthen rural clinical engineering infrastructure by building capacity, providing continued education and appropriate repair tools, building community among the engineers, and standardizing engineering maintenance practices. Over the next few slides, we'll be touching on the project activities that have allowed us to work towards these goals. So the first major component of our project is providing clinical engineers in Ghana's rural north with the appropriate tools. Prior to the initiation of this project, rural engineers in Ghana had to rely on improvised tools to carry out their engineering responsibilities. In order to provide the most useful tools possible, we asked the rural engineers to complete an annual needs assessment, which is used to inform the purchase and assembly of engineering toolkits. These toolkits are donated to the clinical engineers in Ghana's rural north during GMH's Clinical Annual Engineering Conference. So speaking of that conference, this is the second major component of our project, and that is providing clinical engineers with continued training, education, and a community that fosters collaboration. Before the annual conference, a knowledge assessment and questionnaire is completed by the engineers to identify any knowledge gaps and critical training topics. The training curriculum was developed by Ghana's Deputy Director of Clinical Engineering, Mr. John Zana, in collaboration with expert biomedical engineers from both Ghana and Canada. Didactic and hands-on training is delivered by local healthcare workers and engineers, as well as Canadian engineers over Zoom. Furthermore, through our annual in-person training and online communication platform, we have connected engineers across the rural regions, both socially and professionally, allowing them to build their community and provide a space to troubleshoot any real-time engineering problems.
So the final and most anticipated project activity that we have is the introduction of a computerized maintenance management system to northern rural Ghana. So in the context of healthcare, CMMS is essentially a computer program that allows clinical engineers to centralize all of their maintenance data, and it can actually analyze that maintenance data that's being inputted in order to help the clinical engineers make the best possible decisions about how to manage the resources and funding that they have towards their clinical engineering practices. So ideally, what we've seen in healthcare environments that have implemented CMMS, that CMMS imparts drastic improvements to maintenance practices and resource allocations, and this is especially true in low-resource healthcare settings. Now, over the last few years, engineers both from Ghana and Canada have been working together in order to create a context-specific CMMS that is going to be used by the clinical engineers in northern rural Ghana, and we're hoping to conduct a mixed method study comparing outcomes after 1 year of this CMMS use in several of the rural hospitals within Ghana's northern regions. And this study is primarily going to be run by the University of Development Studies, which is based in a town called Wa in northern Ghana. And the principal investigator is going to be a researcher known as Dr. Millicent Akatiba. Now, what we're looking to identify with this study is any facilitators and barriers to CMMS implementation in low resource setting, as well as the impact of CMMS on health technology maintenance, as well as the healthcare outcomes that follow as a result of the fact that there's going to be more clinical engineering standardization. And ideally, the engineers are going to be more supported in making better decisions with regards to how the funding and resources that they have are being used. So today, since our project is relatively new and because of all the hurdles that we had related to COVID-19, most of the data that we have primarily comes from pre and post questionnaires that we had the clinical engineers complete prior to and after the conferences that we hold on an annual basis. And what these questionnaires have demonstrated is that the clinical engineers feel that they are much more competent in their clinical engineering practice, and they feel that their skills have been growing as a result of the training curriculums that we've been implementing. They also acknowledge that they feel more connected to the engineering community within Ghana's rural north, and they feel more satisfied with the work that they're doing. But most importantly, they've demonstrated an intent to remain working in rural environments, which is very important because one of the big issues that Ghana's rural north had in terms of its clinical engineering department is that they only really had a handful of engineers working to maintain and repair the clinical equipment that was available. In terms of the CMMS project, once the study gets underway, we're going to be looking at both quantitative and qualitative data since we're using a mixed method study. The quantitative data is going to primarily come from the maintenance records. So we're going to be looking at stuff like funding, how often equipment stays operable when it's repaired, the downtime for equipment, and other metrics that could be used to assess the overall efficiency of the clinical engineers at the hospitals with and without CMMS. And then the qualitative data is going to come from semi-structured interviews with the engineers, where we get a sense of whether or not they feel that CMMS has facilitated their ability to maintain the equipment at their healthcare facilities. So overall, there's no denying that rural engineers benefit from access to tools and continued education. And we've seen benefits in technical understanding, perceived skills, sense of connectedness, and job satisfaction. And we're hoping that once we do finally introduce the CMMS aspect of this project, the standardization that's going to come with it is really going to help support the engineers to carry out their maintenance duty in a more organized way, and help them make more efficient decisions about how the limited resources and funding that they have should be used in terms of maintaining the medical equipment at their facilities. One of the biggest challenges that we've had, especially when it comes to rolling out the CMMS to different hospitals across Ghana's rural north, is that the local funding for clinical engineers is very limited. So initially, we wanted to roll out CMMS to several intervention sites at the same time, but this ended up proving impossible because of the fact that our funding was so limited. So now we're going to be rolling it out to one hospital at a time. And this has changed our research approach when it comes to the study that we are conducting. But overall, we are anticipating that CMMS will improve the maintenance practices and healthcare outcomes at the facilities that receive them. And this primarily is the result of a literature review that we've conducted looking at CMMS use in similar rural healthcare environments, most of which were based in Africa. And all of the studies that we looked at have shown positive outcomes once CMMS was rolled out in the low resource healthcare settings. So in the long run, we hope that data from our program can be used to inform Ghana Health Services decision-making regarding future funding policies for training programs and infrastructure development as it relates to the clinical engineering sector. And further down the line, the way Ghana Medical Help is organized is that once we've shown that the projects that we've developed are working effectively, we're going to break them down into their core components and package them in such a way that they could be replicated in similar rural healthcare environments throughout the world, including back here in BC. But that's something that's going to come in many, many years from now, once the project is properly up and running, and once we have all of the data to back everything that we're doing. So here are our acknowledgements. Just like the previous presentation, our work has primarily been funded by the RCC BC and their Rural Global Health Partnership Initiative Fund. And here we have a list of all the members of our project team, which is comprised of engineers, medical students, and volunteers, both from Ghana and Canada. And we'd like to thank all members of Ghana Medical Help and Ghana Health Services for their ongoing support with our project. And we're happy to take any questions.
Thank you, Danielle. Thank you, Nicola. That was amazing. Great work. Really interesting. And I love the extrapolation to health science from an engineering perspective. Really interesting. Don't see that we have questions yet. Maybe I'll start off with one and we can see if others. Can you describe a little bit more for me what the CMMS is? Is it kind of like manual instructions, like going through a kind of like maintenance of these types of equipment, like autoclave? Like how does it actually look? What would an engineer actually see in their setting, in their context?
Sure, I can try and answer that, and Nico, you can fill in any gaps. CMMS basically labels all the equipment in the hospital with a certain barcode, and engineers would then log this equipment. And on this log, which is like a fancy Excel sheet, you could say, it tracks when maintenance needs to be done. So it allows you to have a very standardized approach to preventative and reparative maintenance, as well as easily track all different spare parts and equipment in your hospital. So that would allow you to create the most effective preventative maintenance schedule so that you're not having rundown machines, you're not having missing spare parts, and you're also quite easily able to work at various hospitals with this standardized system, as you would then be fully aware of what sort of maintenance processes are going on for what certain machines. And the idea is if all the hospitals in the area sort of follow this standardized approach, they would easily be able to like borrow equipment from other sites. You could reach out to a nearby hospital saying, oh, I know in your catalog you have this number of spare parts. We're short right now. Can we use something? So it just sort of creates that standardized approach to maintenance that way.
The program's also able to analyze how often different types of equipment break down, how much it costs to repair this equipment, how often this equipment is used by healthcare practitioners, which is really important in rural settings because if you have a piece of equipment that's used maybe once or twice a week compared to something that's used on a daily basis, you want to make sure that you're prioritizing the repair and maintenance of the equipment that's used more often or that may be potentially more life-saving. So all of these metrics can be factored in to the decision-making process for the clinical engineers. There's really no limit to what maintenance or healthcare-related information you could add into it. That really depends on what kind of data is available for the clinical engineers and how the engineers themselves want to go about designing the system. So there's a lot of variability.
And is that variability, Nico, was that part of the issues with rolling this out? Like you mentioned, really you could do kind of like one area or site at a time. I'd love to hear more about that. I was curious why there was such a crunch in terms of like numbers that you could start with.
Mm-hmm. The biggest issue that we had in terms of rolling out the CMMS was mostly related to how we were going to be analyzing the outcomes for the sake of this study, because a lot of the maintenance practices within rural Ghana have been pen and paper. A lot of the metrics that we hoped to track. So essentially, we wanted to look at the maintenance data for every facility prior to using CMMS, and then looking at how it's either improved or declined after 1 year of CMMS use. The problem is a lot of the metrics that we hope to use just haven't been documented at a lot of these facilities. So we've been working very closely with Dr. Millicent Akatiba from the University of Development Studies to find a way to work around this lack of data that we're dealing with, because it really limits our ability to demonstrate how CMMS is impacting these facilities when we have no data to work off of, the preliminary data to work off of. But in terms of creating the CMMS itself, we actually did a quick pilot study in the Bolgatanga Regional Hospital where we rolled out a very basic CMMS, and we had one clinical engineer essentially try it out with all of the equipment in the hospital and give us feedback on what he thinks we should add to the CMMS, what he thinks is unnecessary in terms of the data that he's working with, because he has, he's the one who's going to be working with the CMMS and all the other clinical engineers that work with him. So they have the best idea of what type of data is going to be beneficial to them and what type of data is not going to be beneficial to them. So that's how we've been updating what's included within the program.
Interesting. Thank you. Thank you so much. Okay, well, thank you for sharing your work. And again, I love this engineering crossing health and rural, and it's so wonderful to see. We're next going to go to Angela Catlevia from UBC, and Angela is going to speak on the impact and perceptions of medical education opportunities among clinicians in rural Ghana, a case study of novel virtual Grand Rounds program. Thanks, Angela. Looking forward to hearing from you.
Hey, can you see my slides okay?
Yep, everything is good on my end.
Okay, great. Okay, perfect. So hi, everyone. My name is Angela, and I'm a second year medical student at UBC, and I'm at the Vancouver campus right now. And welcome to my presentation on the impact and perceptions of continued medical education opportunities among clinicians in rural Ghana. And this is a case study of a novel virtual Grand Rounds program. And this is a quality improvement project on a virtual Grand Rounds program that was launched by the international medical charity Ghana Medical Help, which you just heard about from my friends Danielle and Nicola. So our objectives for today's presentation are first to give a brief overview on the motivation behind this project. So we'll go over the need for continued medical education in rural Ghana. I'll give a quick description of the pilot virtual Grand Rounds program and how it works. We'll go over some preliminary results and findings, as well as some future directions for the program. So continued medical education, which I will refer to as CME moving forward, refers to a form of postgraduate training that helps those in the medical field maintain competence and learn about new and developing areas in their field, such as new diagnostic or treatment approaches. And the World Health Organization has identified CME to be one of the most important elements in improving healthcare workers' skills, knowledge, and morale. But CME opportunities are quite scarce for clinicians in rural Ghana, which hinders their ability to remain up to date on recent evidence-based practices. All of this contributes to low morale, low clinical competence, and particularly challenges in recruiting and retaining healthcare workers, which then further reinforces health disparities in already underserved, low-resourced communities. So the pilot virtual Grand Rounds program was launched in July of 2021 with the goal of improving access to CME opportunities for rural Ghanaian healthcare workers. The virtual Grand Rounds program are essentially almost weekly lectures where a Ghanaian physician will present on a topic that they have expertise in. So here, these little posters are examples of recent seminars we've had. So we had a seminar recently on rheumatic heart disease, snake bites, pneumonia, and sickle cell disease. So the data that I'll be sharing with you today come from 9 virtual Grand Rounds seminars conducted between January and April of 2022. So what we did was we sent out an online semi-quantitative Qualtrics survey after each presentation. And the survey included 5 demographic questions, which included things like age, gender, and occupation. There were also 5 5-point Likert scale questions where participants were asked to evaluate the presentation they had just watched. And I'll go over what those questions were when we take a look at the results section. There were also 3 open-ended feedback questions where we asked participants to freely share how they had benefited from the program and what sorts of future topics they'd like to see as part of the virtual Grand Rounds presentations. So here's some of the demographic information that we collected from our surveys. So in the top left-hand corner, we asked participants about their field of work. So 46% were physicians, 12% were physician assistants, 16% were nurses, 11% were students, and then 15% fell into this other category, which largely included public health officers, pharmacists, and midwives. Then for the gender distribution of participants, you can see in the bottom left-hand corner, so about 78% of our respondents were male and 22% female. Then in the top right-hand corner, we show the age distribution of participants. So the vast majority of participants fell into the 25 to 45 age range. And in the bottom right, we had a question asking participants how many seminars they had attended up to that point. And the largest group had attended about 2 to 5, and then the rest either more or just 1. So here are the results from our presentation-specific evaluation questions, which were based off of the 5-point Likert scale. So participants were asked how strongly they agree or disagree with the statements shown here. And so the 5 statements were, I have applied what I learned from past presentations in my clinical practice. I will use what I learned from today's presentation in my clinical practice. I would attend future Grand Rounds presentations. Today's presentation was interactive, and today's presentation was helpful and relevant for my clinical practice. So as you can see from this graphic, the vast majority of participants strongly agreed with all the statements, which gave us an early indication that the program was benefiting a lot of participants. I'll also mention here that the sample for each of the questions varies a little bit. So for the bottom 2 questions, there were about 242 surveys that contained this question, but In future iterations of the survey, we scrapped the top 3 questions while we were sort of experimenting with our survey design. So those only have 173 responses. We have since finalized the survey, so hopefully we'll have some more stable data in future presentations. So this is one of our tables from our current manuscript, which outlines some of the qualitative data we've collected from one of our open-ended feedback questions, which asked participants how they had benefited from the program. And I'll clarify here that the Virtual Grand Rounds program is locally known as the Community Service Agenda, which is why the question was phrased in this manner. So the question was, how have you benefited from the Community Service Agenda presentations? So 2 major themes came up from the analysis of this question. So the first one, and the biggest category, was increases in updates in knowledge. So about 67% of respondents to this question gave an answer along the lines of increased knowledge. And on the right-hand column, you can see some of the example quotes that we pulled. So for example, one participant wrote, "It has been helpful in improvement of my knowledge base, keeping me up to date with current trends in common case management." Another theme that came about from about 14.5% of respondents was the application of knowledge and improved clinical performance. So another example quote from this theme was, "Applied the knowledge acquired in the management of a similar situation at the work setting." So now for a brief discussion on some of the early data we collected from our assessment of the Virtual Grand Rounds program. So overall, the program is very feasible. It's been really cost effective and has been well received by participants. Some of the benefits of the virtual format is that it has enabled attendance from healthcare workers who would have otherwise been limited by poor road infrastructure and rainy season weather. We've also recently started recording the presentations and posting them on the Ghana Medical Help YouTube channel. So if participants can't attend live, they can go back and watch the presentations later or use it as a reference study guide. Some early benefits we've been seeing from the program include improved clinical competency and morale, and improved recruitment and retention of doctors in Northern Ghana. So when the program was first launched in July of 2021, there were only 5 physicians in the Upper West Regional Hospital, where this program is based out of. And this hospital supports a population of about 860,000 people. 1 year later, as of July 2022, that number of physicians has over quadrupled. So now there are 22 physicians in the Upper West Regional Hospital, and nearly all of them attend the weekly Grand Rounds presentations. These new physicians reported that they would have previously rejected Northern job postings, but accepted it due to the ongoing learning opportunities that have been now offered to them. This program has also provided mentorship opportunities for young physicians and medical students to connect with other like-minded individuals. So to wrap things up, I'll just go over some recent accomplishments and future directions for this program. So the Ministry of Health in Ghana recently approved the Virtual Grand Rounds program for certified CME accreditation. We've also expanded our medical education program to include annual basic life support and CPR training workshops. The recent iteration of our surveys, so we've been continuing data collection, and the recent surveys have included some other variables, including work district, rural versus urban, and health facility type variables, to add some kind of depth and breadth to our analysis. Our ultimate goal with this program is to make Northern Ghana a hotspot for medical education in order to improve the retention and recruitment of physicians to the rural north. And this has broader implications for lower resource settings globally, including in rural British Columbia, where a shortage of physicians is an ongoing problem. These are my references. And if you have any questions, I can take them now, and you're welcome to contact me or Ghana Medical Help for any further questions.
Thank you, Angela. That was great. Where you said this manuscript, where was this published? Where is this published?
It hasn't been published. We've just, I've been in the process of writing it, and we're deciding whether we want to go forward with publishing, or if we want to instead continue data collection and kind of have like a more rigorous study undergone. But for now, no published.
A couple of questions for you. I'd love just some comments. The recruitment. Oh, Agnes has a question. I'll let Agnes, go ahead.
Hi, thank you. Angela, that was such a great presentation, and the work that you're doing sounds incredible. It sounds like it's having a lot of meaningful impact on the people. I was just wondering what your kind of thought process is like with adjusting the surveys, just because that's where we are at right now with our project. So just wanting to pick your brain to see how you've approached it.
So originally, the reason for adjusting the surveys was to make it less time consuming for participants to answer each survey. I think if you were to adjust them, you should have a pretty solid reason to do so, just because it does make data kind of less structured and less rigorous. But I think my piece of advice is what I'm doing now is just finalizing a survey and kind of running with that moving forward and really sticking with it until you reach a point of data saturation. For us, it was really just to make it easier on our participants and still gain meaningful feedback. But yeah, it really depends on why you're doing it and then kind of what your goals are.
Thank you.
Yeah.
Maybe I'll ask you a question. I know you're kind of focused on the evaluation impact. I love the recruitment aspect of this work. I think that's really amazing. Just a question, how, like you mentioned some of the things around sickle cell, snake bites, how were your topics and learning objectives determined? Like, do you have a local planning committee? And also who's presenting these rounds? Are they local, or do you draw on the global community, or is this done kind of by practitioners and physicians in Ghana?
So the first question, there was a needs assessment done before I was on this project, but the head of internal medicine at the Upper West Regional Hospital, Dominic Akatiba, he is also the leader and the kind of the mastermind behind this entire program. And so I think he did a needs assessment based on initially common clinical presentations at that hospital. So they had things on like pneumonia, malaria, just really common case presentations. And then from that point on, some of the topics have been chosen based on surveys we collected last year. So snake bites, which was in November, that presentation was a requested topic from like one of our January surveys. So some of them are being pulled from there. Another way that we're choosing the topics, which is kind of tangentially related to your second question, is the people who are doing the presentations have some expertise in certain topics, and so they'll present on that topic. And the way that they're being selected is they are all local. Some of them are actually residents that have interest in like a specific area of medicine. For example, we had one resident that was really interested in pericardial effusions, and he did a presentation on that. And so it also gives them kind of an opportunity to practice their teaching, their presentation skills, things like that. So it's sort of at this stage, not a very systematic process. It's sort of just based on requests and then the interest of local physicians that want to present.
Great, but I think that follows best practices in CPD and medical education. A lot is determined from needs assessment planning committees, so great work. And then it sounds like most of the faculty or presenters are local from Ghana. Is that kind of the consensus?
Yeah, the vast majority are actually working in the rural north. And then there's a couple from the capital, but the vast majority are from the Upper West region of Ghana in the rural north. Great.
Thanks so much, Angela. This is fantastic work and really interesting. Congratulations to you and your research team.
Thank you.
We're going to go to the last presentation of this session. Dr. Naseem Madami from UNBC, and she's going to present work building dialogues for clinical research, collaborations, and leadership in Northern British Columbia. Over to you, Naseem.
I think I would remember to unmute myself by now, 2 years post-pandemic, or we're still in pandemic. Good morning, everyone. Thank you for having me here today. My name is Naseem Madhami, and I'm a postdoc research fellow at UNBC School of Nursing. Before I begin my presentation on building dialogues for clinical research collaboration leadership in Northern British Columbia, I would like to acknowledge my team members, Dr. Davina Banner, Shayna Dolan, Kieran Gegg, Jessica Forrest, Cyan Lamole, Julia Beckford, Robert Olson, Jacqueline Peterson, and Denise Warsky, who have all been very instrumental in the conduct of this study. I would also like to acknowledge that I do come to you today from the traditional, ancestral, and unceded territories of the Coast Salish people. This includes the territories of the Musqueam, Squamish, and the Tsleil-Waututh people. I come to you from Vancouver, UBC campus. So it does not, I don't think, come with surprise to anyone within this room that the health outcomes of those in rural and northern BC continues to lag behind the rest of the province, with burgeoning rates of chronic disease and more limited access to healthcare services that contribute to poor health outcomes and lower life expectancy. We also know that innovative clinical research, including clinical trials, can provide a critical vehicle through which we can advance the delivery of healthcare services and address problematic health conditions. However, we also know that those individuals, the population within rural communities, have traditionally been excluded from clinical research. And this has occurred in part due to the lack of clinical research capacity and infrastructure, along with challenges arising from the inclusion of geographically distanced and dispersed populations. And so there has been a growing call to address equity in the context of clinical research. And that brings us to this study. So the objectives or overarching objectives of our study was to bring academics, knowledge users, and community stakeholders together to kind of systematically examine barriers and facilitators of clinical research, and to identify priorities and establish a plan to support ongoing research to enhance clinical research capacity and leadership in Northern BC. We had 3 overarching research questions that guided much of our study, and these included: what factors contribute to clinical research capacity and leadership in Northern BC? What are the barriers and facilitators of clinical research in Northern BC? And how can we really learn from each other to sustain and cultivate continued clinical research growth in Northern BC? This study actually was guided by integrated knowledge translation, which is a research approach that requires meaningful engagement and shared decision-making. It does involve a 2-phase study. The first phase, the aim was to examine the factors that contribute to clinical research capacity and leadership. The second phase, phase 2, involved, or the goal of it was to develop clinical research priorities and a future for research plan. The presentation that I will provide you with today actually focuses on phase 1, which is examining the factors that contribute to clinical research capacity and leadership. We obtained Harmonized Research Ethics Board approval before we conducted our data collection, where we engaged in data collection. We had 18 diverse participants that were recruited and participated in this study. And these included knowledge users and community stakeholders and researchers. Data was collected from February to August of 2022. We engaged with semi-structured interviews, all conducted by one of our researchers. And these interviews lasted about 45 to 60 minutes over Zoom platform. And we asked various questions, some of which are examples included here, asking them about what their roles, their specific roles are pertaining to clinical research within Northern BC, asking them about their experiences with engaging with clinical research, and asking about both challenges, but also facilitators that have helped them to engage with clinical research. Data analysis was actually conducted by 3 different researchers. Interviews were recorded and transcribed verbatim, and we used Brown and Clark's thematic analysis for our data analysis. There were 3 key themes that were actually generated from the data analysis of the data, and these included clinical research lacks a formal definition and was understood differently by different participants. There is a new culture of academia and research that is emerging in rural and remote hospitals, and that Northern BC is actually interested and very much so invested in clinical research, but there is a lack of infrastructure, and this is a huge barrier for individuals to engage with clinical research. So the first theme that was generated, clinical research, lacks a formal definition and was understood differently by different participants. And this was an interesting one for us because while the concept of clinical research is actually one that's readily taken up in everyday in healthcare context and research settings, we actually learned from the participants that this notion of clinical research can be understood differently and in different ways. And the definition really depended on whether what their role was and what their experiences had been with research. All of the participants expressed the need to clarify the meaning of clinical research and define its borders. And the definitions of clinical research that were provided by the participants were broad in nature, and they actually varied substantially with respect to the context of where the research takes place. So whether it's in the hospital or community research or within the lab. And I provided some examples of quotes here from the participants for you to view. Furthermore, an element of clinical research that was actually consistent across the definitions was that clinical research needed to involve patients and people and humans. It had to involve them and it had to be about them. And as well, when considering how clinical research is defined and understood, participants also commented that research must have this overarching goal, which was to improve patient care. So these were the two themes or the two descriptions that were consistent across all. With respect to the second theme, that there is a new culture of academia and research emerging in rural and remote hospitals. In describing their experiences with conducting clinical research in Northern BC, many participants referred to their perceptions of this value for clinical research and how this could be used to enhance the quality of care that is delivered. However, many participants also felt that this value of clinical research was in fact hidden or unclear to patients, communities, and healthcare providers. These are the frontline healthcare providers. And some participants felt that this was evidenced by the absence of clinical research within practice. And in comparing northern and urban hospitals, participants spoke to this world of academia, where research is valued and intertwined within clinical practice. And this is one thing that is actually associated with urban hospitals and not so much rural and remote hospitals. Participants also describe how this mindset of academics has only recently been taken up within the rural and remote hospitals. The participants in this study routinely also referred back to the mandates of the many organizations across the Northern BC, where the delivery of healthcare was perceived as the #1 priority for all clinicians involved in patient care. So in the context of extreme and persistent shortages of human resources, especially in the context of the pandemic, then clinical research within practice actually takes second place when we talk about priorities. An overall issue of the limited human resources in the context of heavy patient care resulted in limited time for clinicians to pursue clinical research questions that they were in fact interested in, limited time for clinicians to engage in training relevant to research, and attitudes and culture within the Northern BC where research was not highly valued. The need for appropriate equipment and space was also another key pillar that was described by the participants as a fundamental need and one that was really truly missing within Northern BC. The need for research talent and personnel was also another key pillar that was highlighted, that there needs to be more recruitment of those talents, of those research talents, and retainment of them. So not just the recruitment, but also retaining them. Many participants commented on the need for supporting development and growth and retention of clinical research within the academic and the community settings. And this notion of need or resources also pertain to both informal and formal research training. So there was a lot of consistency with respect to perceptions that there is a need for both formal and informal research training for those clinicians who are in fact actually interested in conducting research and bringing research or clinical research within their practice. So this first phase of our study explored the complex clinical research ecosystem in northern region of BC. It identified many barriers and some facilitators to engagement in clinical research, and identify pragmatic strategies to increase capacity building, collaborative partnerships, and leadership that foster greater equity-informed clinical research. We have actually also engaged in the second phase of the study and have collected our data, but due to the limited scope of this presentation, I could not present the findings of that phase. I welcome any questions.
Thank you. It's a great presentation for the end or towards the end of the session, and very interesting work. Maybe we'll just pause a second here and see if anybody has a question. You can raise your hand and just ask or put it in the chat. Maybe I'll just start. So you mentioned kind of like the clinicians having time, and also like some of the physical aspects of labs. How might that, the second part, how might that actually look? Like, is this about creating more laboratory settings in university infrastructures? This is about ways of collecting data more in the field around where the clinicians are. Any thoughts on that kind of pillar or that finding?
It's a very interesting question. So this notion of physical resources, actually, if you can think about it in different layers, there is the physical space of it, as you mentioned, the physical lab space of it, but physical space was also spoken about with respect to proximity to one another in terms of one researcher and another researcher, and how close we are together in terms of physical space and how that can promote collaboration. Other resources that were talked about that kind of can fall under that bucket of physical space or resources is having access to life labs was huge for clinical trials. So especially when we talk about or we think about really remote areas of northern BC, and how there's a lot of barriers to patients being able to engage in clinical trials because they don't have access to life labs. So it's quite complex, as you can imagine, but it's not just the pure of creating that space, that physical space, but there's a lot of complexity that needs to be thought about. And I wish we could say we could throw millions and millions of dollars into it and it would work, but it's not that simple.
Great, thank you. Okay, let's just see if anybody has a question. Otherwise, I might wrap us up. We're coming up to 12:20. Thank you, Dr. Adami. This is great work, and I'm glad to see that Julia's involved with this, and I think you've got a great champion in the north with Nadine and Dr. Winwood, and I'd love to see, I think there's been a lot of work in the north with databases for northern research, and so I think this is great and provide some recommendations, very practical. So thank you to the BC Research, to the BC Rural Health Research Exchange for hosting us all today. I know myself, I really enjoyed the sessions a lot and learned a great deal. A big thank you to the presenters and the attendees, and just two reminders. The sessions are recorded, so if you've missed something that you're interested in or want to rewatch, this will be made available. And please feel free to reach out to colleagues, and I think Tracy's going to put her email in the chat in case there's any questions or you need to create connections through Tracy. So thank you, everyone. It was a great session, and I wish you all a great rest of your day. And again, thanks to Tracy for doing a great job on the technical end and making everything run smoothly. Thanks, everyone.